Good morning, everyone, and welcome to the Department of Children, Youth and Families Oversight Board meeting today. It's some of us are in the room here in Olympia, and it's really good. I have to tell you, this is the first meeting since I've been co-chair of this Oversight Board that I've had an opportunity to have an in-person meeting. So the only thing I wish was different is that we were all here. So it's good to see you on the screen, and looking forward to a great meeting today. So my name is Tom Dent, Representative Dent, and I'm currently serving as the co-chair along with Sharonda Shelvanoff. So we will make some remarks here in a few minutes. So we have a pretty good, a couple of good presentations today. One from Patrick Dowd from the Office of Family and Children's Ombudsman. We have Secretary Hunter here from the Department of Children, Youth and Families too, and that will happen after our break at 12:30, I believe. So anyway, so this morning, first we're going to hear from Patrick Dowd, the Director of Washington State Office of the Family and Children's Ombuds. And the Office of Family and Children's Ombuds annually conducts child fatality and near fatality reviews for youth in care of DCYF who are in care at the 12 months prior to the event under review. In August, the Oversight Board received the Ombuds Office 2022 Critical Incident Report describing child critical incidents relating to child maltreatment occurring between January 1st, 2019 through December 31st, 2021. This report includes 124 recommendations made to DCYF as a result of fatality and near fatality reviews and the implementation status of those recommendations. So today, Patrick Dowd, the Director of the Office of Family and Ombuds, will present the content of this report and be here to answer questions from the board. So Patrick, thank you very much for being here today, and it's yours.
All right, thank you very much.
Yeah. Sorry.
Oh, excuse me, I forgot. I got ahead of myself.
Okay.
As normal. So is Sharonda, do you have some opening comments you'd like to make?
The only comment I will say is welcome to everyone. Thank you so much for joining us today. I want to extend a very special welcome to the public who has joined us also, and looking forward to hearing from Patrick and Secretary Hunter. So that's it.
Thank you, Sharonda, and I appreciate that. And I did get ahead of myself a little because I was excited to hear from Patrick. We've been sitting here visiting for the last 30 minutes, but we do need to do the roll call and then hear the minutes. So Krista, could you do the roll call?
Morning, everybody. Board members, please unmute yourself and let me know you are here when I call your name. Katie Byron.
Present.
Thank you. Justice Bobby Bridge.
Here.
Thank you. Ben DeHaan.
Here.
Co-chair Representative Tom Dent.
Here.
Sydney Forrester.
Good morning, everyone.
Morning, Sydney. Lonnie Brenniger.
Good morning, I am here.
Morning. Ruth Kagi.
Good morning, I'm here.
Dr. Diane Levy. Charles Loeffler.
Here.
Lois Martin. Co-chair Sharonda Shelvanoff.
Here.
Sharonda. Representative Tana Sen. Senator Judy Warnick. And Senator Claire Wilson.
Present.
Thank you, Senator. And we have our Assistant AG, Kristen Lamson, in the room as well for board members. No. So
Could you read the minutes, Krista, from the previous meeting?
So now I will read through the minutes that the draft minutes the board members have received that capture the previous meeting. The last time the board met was on Thursday, June 21st from 10 a.m. to 1:30 p.m. The first agenda item was DCYF's juvenile rehabilitation updates. Presentations were provided by the Assistant Secretary of Juvenile Rehabilitation, Felice Upton, and Haley Lowe, an institutional education administrator, as well as Andrew Fox, DCYF research supervisor. Assistant Secretary Upton updated the Oversight Board on changes to JR since the board last received information on the division in the summer of 2020. A major focus of changes in JR for the last few years includes the implementation of JR 25 legislation that has transformed the demographics of the JR population. A result of these changes is that the average age of youth and young people in JR is increasing, as well as the average length of stay, while simultaneously admissions and overall population count are exhibiting downward trends. Data from state fiscal year 18 to 21 illustrates that the racial and ethnic disproportionalities continue to exist in the JR population. Assistant Secretary Upton noted that although the overall population in JR is decreasing, the needs of those being served are increasingly more complicated, particularly in regards to higher behavioral health needs. The division is being intentional in addressing the unique needs of a growing population of young people ages 18 years and older. Assistant Secretary Upton emphasized JR's focus on the experience and well-being of both youth and young adults residing in JR facilities, as well as JR staff. To do so, the division has focused on the three main strategies: data-driven decision-making, building staff efficacy and resilience, and providing a therapeutic environment. Other areas of improvement and progress in JR were highlighted in descriptions of the room confinement project, the implementation of House Bill 1186, community transition services, behavioral health investments, and risk assessment improvements. Haley Lowe provided a detailed update on work underway to improve educational outcomes for youth and young adults in JR. The passage of House Bill 1295 provides a roadmap for the agency in partnership with other state agencies to create a foundation for all students to succeed with adequate and appropriate supports. With a focus on equity and education, the agency has developed recommendations to ensure students have a clear plan when they exit JR to continue their K through 12 or post-secondary education. After this presentation, the board had an opportunity to ask questions with the panel. Board members inquired how JR is measuring progress and outcomes for young people and staff for each initiative and project area. Additional questions explored the development process of the new JR risk assessment tool, as well as challenges regarding staff turnover and how the agency is addressing those challenges. Board members also praised the progress and changes made under Assistant Secretary Upton's leadership. We've also captured public comment. There were 2 individuals that participated in public comment during the meeting, as well as 2 that submitted written public comment that are captured in the minutes. The second agenda item was the DCYF Racial Equity and Social Justice Team Updates presented by DCYF Secretary Ross Hunter and joined by DCYF Racial Equity Social Justice Administrators Yvette Jasper and Day Shogren. Secretary Hunter led the conversation on progress and changes the agency has adopted over the past 2 years to advance racial equity and eliminate disproportionalities. DCYF has identified that eliminate racial disproportionalities and advance racial equity as the agency's top priority in its strategic and equity plan. The agency is operating from the theory that it's fundamental to eliminate racial and ethnic disparities in order to make progress in any other strategic priority or legislatively mandated performance outcome. Secretary Hunter described planning and policy progress to achieve this goal, including the establishment of DCYF's pro-equity anti-racism team, the implementation of an agency-wide racial equity social justice policy, and the operations and expectations of an internal DCYF inclusive racial equity change team. Additionally, Secretary Hunter reviewed racial and ethnic data across the system of care and explained to the Oversight Board how the agency is working on being responsive to how data trends are changing. Other specific changes aiding the advancement of racial equity include the implementation of child-specific licenses, actions and funding to sustain childcare through the pandemic, the passage of House Bill 2050, which is repealing parent pay statute, and House Bill 1186, community transition services, the closure of the Nassau Youth Camp, increased high school graduation rates at Echo Glen, and the Office of Innovation, Alignment, and Accountability's commitment to tracking performance outcomes disaggregated by race. The board had an opportunity to ask Secretary Hunter additional questions. They asked several questions on racial equity and agency policies regarding diversity of the agency's leadership,
Krista, I think, are you muted?
Thank you, Lonnie. So the board had an opportunity to ask questions focused on population being served by Working Connections childcare, families involved, specifically those families involved in child welfare and their access to childcare, the relationship between the length of stay and out-of-home care and kinship care rates in King County, and the importance of presenting balancing indicators when focusing on priorities such as safely reducing the number of youth in out-of-home care. DCYF will provide data and follow-up response to the Oversight Board questions following the meeting. And the meeting was adjourned at 1:30.
Thank you, Krista. Do any of the board members have any additions or corrections to the minutes we just heard? Hearing none, the minutes can stand as read. And Krista, I believe that Dr. Levy has joined us since you called the roll. So
Thank you.
very good. Good to see you.
Sorry, I was a little late.
That's okay. I was an hour and 15 minutes early. So that's how excited I was to be here today. So anyway, I am excited. It's really good to be here in person. So now, Patrick, I'll turn the meeting over to you. Thank you.
Just advance. Good morning, members of the DCYF Oversight Board. My name is Patrick Dowd. I'm the director of the Washington State Office of the Family and Children's Ombuds. And I want to thank you for the opportunity to present information about our 2022 child fatality and near fatality report. This report covers child fatalities, near fatalities, executive reviews, and the recommendations that were forthcoming from those reviews and the implementation of those recommendations between January 1st, 2019 to December 31st, 2021. Our office is responsible. Excuse me.
My apologies, we're going to share the screen.
Is that better?
Sorry, yes.
Okay.
No one can see the slides.
All right. Thank you. Again, this report covers fatalities and executive reviews and the recommendations that were made in the implementation status of those recommendations that occurred between January 1st, 2019 and December 31st, 2021. The Ombuds Office is actually required to produce this report annually. For a variety of factors, we were a few years behind, and that's why this report covers a larger period of time in reporting on these critical incidents and the recommendations. So the Department of Children, Youth, and Families notifies the Ombuds Office when a critical incident occurs, and that includes child fatalities and child near fatalities, as well as cases of recurrent maltreatment, which is when there is a CPS finding of abuse or neglect regarding a family, or three or more findings of abuse or neglect occurring within a family over a 12-month period. We're notified through the administrative incident reporting system operated by the department. When our office receives.
Apologies, everyone. We're trying to make sure that those slides are advancing on your screen as well.
That's never gonna happen. We're gonna figure out how to do this. We'll try for yours.
Now it's, I'm gonna try to turn mine, or now we can do it just from that screen.
Oh, does this work? Does it work if you just tap down?
Sure, I could do that, whatever. Yeah,
Okay.
if you, so use this view and just click on the next slide to advance.
Yeah, I should be able to use the arrow.
Okay.
Just down. Yeah, sorry, Patrick.
And is that working right?
Yes, now it's showing up.
Okay.
Thank you for everyone's patience.
So again, our office receives notice by the department through the AIRS, or the Administrative Incident Reporting System, when there's a child fatality or near fatality that is known by the department. So we are not reviewing every child fatality that occurs within the state of Washington, but rather those that the department becomes aware of, generally through a report to Child Protective Services or involving an open case with the Department of Children, Youth, and Families. Not all of the child fatalities or near fatalities that we receive notice of are related to or abuse or neglect. So once we receive these reports, we are looking at what are the circumstances around this critical incident. We're also interested in, are there other children in the home? Is the department taking appropriate measures to ensure the safety of those children? And then we're also doing a deeper dive into the circumstances regarding that fatality or near fatality to determine whether or not that critical incident was directly related to child maltreatment. There are also other types of critical incidents that are included in the AIRS reporting system, and those are included in this slide, such as placement exceptions, staff safety issues, maltreatment that occurs within a licensed facility. So this slide shows over the last, 9 years, I think, tracks the number of reports that our office received of child fatalities. The blue line shows kind of that total number. I hesitate to draw specific conclusions so for example, you could look, wow, there's been an increase in the number of child fatalities from 2019 to 21, from 51 to 77. I'm not sure what that means. I don't know if the numbers are large enough to be statistically significant. But I think the main takeaway from this slide is that the blue line again represents notifications of child fatalities. Not all of those are related to abuse or neglect. Some may have been medically expected, some are clearly accidental. The orange line represents, of that total number of child fatalities, the orange line represents fatalities where, after our review, we determined that the fatality was in some way related to child maltreatment. It does not mean that the specific cause of the fatality was child abuse or neglect, but that there were factors present or concerning history within the family that may have contributed to that child fatality. And then the gray line represents the number of fatalities that were clearly related or caused by child abuse or neglect. And those are the fatalities that receive an executive review by the department. Who determines whether it's directly related or caused by abuse or neglect? That's usually based on CPS investigation that concludes that the parent or caregiver is founded for abuse or neglect related to the fatality, or it could be a law enforcement finding or a medical examiner or coroner's conclusion that the death was caused by abuse or neglect. And again, this kind of captures that same information in a different form by each of the past 3 years. So in between 2019 and 2021, there were 14 child fatalities that were clearly caused by physical abuse, and another 32 that were caused by neglect. And then the bottom line, or the blue, captures those cases where our office identified concerns regarding child maltreatment that may have contributed to the fatality. So an example of that might be an infant fatality, and the medical examiner concludes it was sudden unexpected infant death. And so there was no finding of abuse or neglect. Our review of the case history may have found documentation of a history of substance abuse issues by the parents that may have contributed to that fatality. We're not sure. We can't establish that definitively. It does not rise to a level of the statutory duty or mandate to conduct an executive review. But we believe it's worth documenting and identifying those child maltreatment related concerns. We also tracked race, ethnicity of the children of these child fatalities. And again, I hesitate to draw any specific conclusions based on the size of the number of child fatalities reviewed. But what we noted that the percentage of maltreatment-related fatalities of African-American and Black children decreased between 2019 and 2021. But however, maltreatment-related fatalities of American Indian and Alaskan Native and multiracial children increased. Okay, this slide documents the family's contact with the Department of Children and Youth and Families at the time of or prior to, within the 12 months prior to the critical incident or fatality. And what we found was that 40% of the families involved between 2019 and 2021, 40% of the families involved had an open case with the Department of Children, Youth, and Families at the time of the fatality. And that represents 36 of those 36 families. And 36% had a closed case within the previous 12 months or 32 families. So this slide shows, well, what type of family involvement occurred with the department. And this slide kind of tries to quantify, was that Child Protective Services? Was it a family assessment response or voluntary services or child and family welfare services? And what we found were that there were 19, so of these 36 families, that had an open case at the time of the fatality, there were 19 families with an open CPS investigation. 8 families were receiving child and family welfare services. 4 were open to family assessment response, and 5 were participating in family voluntary services. And this table also describes, well, where was the child placed? Was the child in the home? Was the child with a relative or in licensed care? And what we found was that there were, again, of these 36 child fatalities that occurred with an open DCYF case, 30 child fatalities occurred when the child was remained in the parent's care. There were 3 child fatalities that occurred while the child was placed with a relative. 1 child fatality occurred with the child placed with a suitable other or suitable adult. And 2 child fatalities occurred while the children were in a medical facility. And these were twins that were born premature that was related to in utero drug exposure, parental substance abuse, following the child's premature death with significant medical issues. The child remained at a medical facility and then later passed away. Our office was also interested in the occurrence of child fatalities after a child is the family's been involved in a dependency. Child has been removed from the parent's care. The parents engaged in services, and then the child is returned home. And what we found was during the same time period, there were over 10,000 children that were returned to the parents' care after being removed by the department. That doesn't mean all of these 10,618 children were in a dependency. It's not uncommon that a child might be temporarily removed through a pickup order or a child being placed into protective custody by law enforcement. And then within the next 24 to 72 hours, the department might identify an appropriate non-custodial parent, and the child's placed with that parent, and it does not necessarily result in a dependency, for example. However, I think this is provides some background information that is certainly relevant. Additionally, 60% of the children that exit DCYF care are reunited with their family. And what we found of the 37 executive child fatality reviews that occurred between 2019 and 2021, there were 4 cases where the children had been removed from the parents, involved in a dependency, and then returned to the parents' care following in the course of that dependency proceeding, and then a fatality occurred. Those 4 cases involved 5 children. So this slide shows the prevailing risk factors that are associated with child fatalities. And I don't think this is really shocking or much of a surprise. It's mental health issues, substance abuse issues, and domestic violence issues. And, you know, those are the primary issues or factors that also lead to families' involvement with child protective services. And those same factors are, I think, to no surprise, also reflected in child fatalities. And this slide also documents the age of the child at the time of death, and this is consistent with previous reports that we found. And again, I don't think it comes as much of a surprise that children between the age of 1 and 3, and specifically children between the ages of 0 and 12 months, are at greater risk. And that's where we see the highest number of child fatalities. So for at least probably the last 10 years, there's been a focus on safe sleep and infant fatalities that result of unsafe sleep practices, infants co-sleeping with parents and or other siblings, infants not being placed in a appropriate crib without numerous blankets or pillows or stuffed animals, et cetera, but making sure the child is in a safe sleep environment, ensuring the child is placed down on the back, that the parents are not using other infant-related products that are not intended for sleep, such as boppy pillows or these horseshoe-type docking stations that are marketed. And there has been a public health focus over the last at least 10 years to reduce the number of infant fatalities related to unsafe sleep practices. It goes beyond the Department of Children and Families, Department of Children, Youth and Families, and CPS's efforts to educate parents when there's involved with the department, and to review the child's sleep environment. All of these practices have been integrated to reduce infant fatalities related to unsafe sleep environments. But it goes beyond that and has also included public health education efforts through medical providers, pediatricians, et cetera. And it's been somewhat successful. We've seen a reduction from 76, 75% down to 54% this past year, but it also shows that there are far too many preventable infant fatalities that are related to unsafe sleep.
Patrick, can I have a quick question?
Yes.
So, I think I know the answer, but I want to be clear. So the fatalities that you've looked at, you've come up with this data, are most of these cases have come out of, these people have been involved in the system and DCYF, and the children been in and out of the home. Is that correct?
That's correct. So let me jump in. The department conducts an executive child fatality review when the fatality is attributed to child maltreatment, abuse, or neglect, and the family has received services from the department within the preceding 12 months. That might be an open case with the department at the time of the fatality, or it might be, for example, a family assessment response that occurred 8 to 12 months prior to the fatality, and it's a closed case. So that is those are the cases that receive a fatality review. In addition, if there is a fatality that the department becomes aware of, that is included in the administrative incident reporting system, then that also is included in the data and the cases that we review. But it might not meet the qualifications for the department to conduct an executive review.
But this slide, the data set here is all of the ones we know about, right? It's not just the ones we did an executive review on, it's the larger category.
Correct.
That's what.
Yes.
So
Yes,
it's,
so
so
this-
this we found out about, but we might not have been involved in every single one of those.
That's right.
So it would be possible then for you to investigate a fatality from, say, possible unsafe sleep concerns from a family that has never been involved in the system. The family lives down on the corner and their child dies. Could there be any way that they could be included in this?
Yes.
Okay,
So it's possible that a family would have had no prior involvement with DCYF.
okay.
And there is a infant fatality that is attributed to unsafe sleep. And that might result in a CPS referral, a call from the hospital to CPS saying, this infant was just brought in. We're still not sure what led to the fatality. And, but if there was no prior involvement with the department, it would not necessarily receive an executive review, and it would be included in these numbers, but would not be a case where the department had previously been involved with the family.
Understand. Thank you.
So our report also kind of documents youth suicides. And I think this is an important topic to discuss and review. Youth suicides generally do not receive an executive review, even when the family has had as an open case or has had previous involvement within the last 12 months. And the reason for that is it's unusual that the suicide is directly attributed to abuse or neglect. There are some circumstances where that is true, and it then receives an executive review. So an example of that might be a youth where the caregiver knows that a youth has suicidal ideation, perhaps previous suicide attempts, and there is a gun that's unsecured in the home that the child has access to. So that might be directly related to neglect. That might qualify for a review. But for the most part, that's not the general circumstance. And so there could be an adolescent that's in our foster care system or that is involved in an open case with the department, who dies by suicide and there's no indication of abuse or neglect that contributed to that death by suicide. And so it doesn't receive a review. And so we don't have that opportunity to drill down into that case and say, well, was there an opportunity to intervene in some way, provide services? So that's why I wanted to kind of draw some attention to this issue in our report. Children in foster care are at a greater risk of suicide, largely attributed to the trauma that they've experienced, trauma related to maltreatment, trauma related to being removed from their family. In Washington State, suicide is the leading cause of death for youth ages 10 to 17. This is not peculiar to Washington State. This is a national issue. OFCO reviewed 297 critical incidents, and of those, we found that there were 20 deaths that were attributed to suicide, and additional 8 attempted suicides. And our report recommends that the department consider having caseworkers conduct using a screening tool when a child comes into care, screen a child for suicidal risk, and conduct those screening periodically throughout the case. That's kind of one possibility. And also provide training for caregivers, foster parents, relatives for children that are in state care, and educate them about kind of warning signs regarding suicide or suicidal ideation, provide education and training about supportive factors to prevent suicide, and also educate caregivers about accessing services that are available in their community when there is a concern about the child's welfare. Again, this is another slide on youth suicide by age. You know, the greatest risk is between 14 and 17. Again, I've said this before, I hesitate to draw conclusions based on a very small sample size, but this, again, we try to, as much as possible, report out on race and ethnicity in our reports. Okay, and here were our recommendations, again, that kind of utilize a universal screening tool to screen youth when a child comes into care, and then at regular intervals, and then provide support for foster parents, relative caregivers, and parents about risk factors and warning signs, and support and how to access professional help. So our report doesn't spend a lot of time on the same type of data collection on near fatalities as we dedicate on child fatalities. But this is a similar graph that shows the number of near fatalities reports that we received, and that's the blue line. Again, not all child near fatalities that are reported are attributed to child maltreatment. And then the orange line represents those where, based on OFCO's review, we thought that there were some factors related to child maltreatment that might have contributed to that critical incident. And then the gray line are those that are directly attributed to child abuse or neglect and would receive a executive near fatality review. All right, so now I'm moving into the section dealing with, all right, now we have a fatality or near fatality, and it's definitively caused by or related to child maltreatment. And the child or family was receiving services from the Department of Children, Youth, and Families within the preceding 12 months. So those are the pool of critical incidents that receive a executive review. There's a distinction between child fatality executive reviews and near fatality executive reviews. And the main difference is that the executive fatality reviews are published and posted on a public website maintained by the Department of Youth and Family Services, whereas near fatality reviews are not. And the same, there are federal and state laws governing confidentiality that allow the department to publish reports, redacted reports regarding child fatalities. And they do not have that same ability when reporting on near fatality reviews. With that said, our report includes recommendations from both near fatalities and fatality reviews. And so those are included when we're reporting out on the implementation status of those recommendations from these reviews. I want to spend a little bit of time to kind of summarize what these fatality reviews and near fatality reviews look like. So the department facilitates these reviews. The review team is made up both of individuals kind of within the department as well as from the community. So it is not an internally driven process or structure. The facilitator will identify committee team members from both representatives from our office. OFCO participates in each of these fatality and near fatality reviews. And then they also identify members from the community to serve on the review team. And that's often determined by the nature of the critical incident. So for example, if the fatality was related to chronic abuse and there was a law enforcement investigation, there would very likely be a law enforcement representative on that review team. There would likely be a member from the medical community, perhaps a pediatrician that is experienced in identifying signs of injuries that are related to abuse, for example, or alternatively, if the critical incident was related to domestic violence and substance abuse, then the facilitator would draw on community experts in substance abuse treatment or domestic violence programs as well. So we're bringing in that local expertise to advise the committee members and guide the team in reviewing the case. All review team members receive confidential case records regarding the case in advance with the expectation that at the time of the review, everyone is well versed in the family's history with the department, and also have the opportunity to provide the facilitator with questions that they would like to see addressed at the review. The review usually begins with a meeting of the team members and the facilitator. We discuss the family's case history with the department's involvement. identify specific issues that we would like to learn more about in the course of the review. And then following that, then the interviews are conducted with the caseworkers and supervisors that have been involved in the case. I think it's also important to note that these reviews are almost like a window into the department's operations and the way the case was handled. So very often, and I think the majority of the recommendations that come from these reviews are not necessarily directly related to the circumstances around the child fatality or the near fatality. So for example, you could have a review team that is reviewing an infant fatality that was related to unsafe sleep. Parents were co-sleeping, parent rolls over on the infant. That is what caused the child's fatality. The review team might have questions about, well, at the beginning of the case, did the department fully assess domestic violence issues that were related to the parents' relationship? Or did the parents, you could have a situation where there was multiple children and one or more fathers that are involved. And what efforts did the department make to engage the non-custodial parent? So the review team has wide latitude in reviewing these cases. So I think it is important to note that the recommendations that come out of these reviews may be related to important but very ancillary issues that were identified that may not directly relate to that fatality. Okay, so between, or one other comment on that. So then after the review committee, after the interviews are conducted, the team will then regroup, discuss, possibly discuss, were there any findings? Were there any significant deviations from practice procedures, legal requirements in managing a case? Or are there areas that might not be a violation of our policy, but should be kind of identified and discussed? Are there areas that we can improve kind of the way that the system engages with families? And then there's also an opportunity to make recommendations. There are times where a review will be completed and no recommendations will be identified. That certainly happens. After that, the facilitator drafts a report. It's circulated among team members, then have an opportunity to provide feedback before that report is finalized and then published by the department.
So I have a question on the team,
Yes.
how it works. So you did say that the review team would be made up of local people as well as some folks from OPCO, right? So, and then could you give me an idea of how large these teams are? And, maybe, I mean, is there an equal number of local people compared to OPCO, or is it different? I mean, give me an idea just what they look like.
So in addition to the facilitator, there's usually perhaps a quality practice specialist within the department. There might be another representative from the department, and any of the representatives from the Department of Children, Youth, and Families are individuals that have had no involvement, in the case. So, for example, if it's a critical incident from the King County area and Region 4, there might be a quality practice specialist from Region 1 in Spokane that participates in that review. And then it's a pretty good balance. I would say in general, there might be 6 individuals serving on the team. So it would be perhaps myself from the Office of the Family and Children's Ombuds, an individual with expertise in domestic violence. Maybe if it was, there could also be cultural or ethnic factors. So if it involved a Native American family, they would ideally want to have a representative from a Native American tribe serving on the team as well. So there's usually, I would say, maybe 3 or 4 individuals completely outside of the department, and then perhaps 2 or 3 that are employees of the Department of Children, Youth, and Families.
Thank you.
So again, timeframe January 1st, 2019 through the end of December 2021, the department conducted 37 child fatality reviews and 40 near fatality reviews. And those resulted in 124 recommendations. And this shows kind of, so what did the department do with those recommendations? In kind of recently, the department established a process for quarterly, a team made up of upper administration within the department reviews those recommendations on a quarterly basis and determines if and how to implement those recommendations. And then in preparing our report, we also track those recommendations and gather information from the department of were they implemented? Were they implemented statewide? Was it a region or local recommendation that was made? If it's in the process of being implemented, or if the department determined, no, we're not implementing that, then, well, why not? And what was the basis for that decision? So this table kind of outlines kind of what was the result, and it tracks whether it was implemented, whether it's in progress of implementation, did the department consider but decide not to implement it? And it's also not uncommon that the review team will make a recommendation that might reflect what is already currently in practice. So there's a segment of recommendation where the department reviews it and says, you know what, this recommendation, we agree it's great, but it's already addressed in our current policies and practice. And the table also identifies whether it was statewide implementation, regional, or a local office. So sometimes the review team will identify an issue about a local office that might not have statewide implementation. And that might be, you know what, it seemed like that there was a gap in communication between this office and law enforcement. And that should be addressed. And the recommendation might be that local officer, the regional administrator should make sure that there is a streamlined communication process between the local office and the county sheriff's office or that city's police department. We also, in our report, we try to categorize kind of recommendations by topic areas. And this was what this slide depicts. About 30% of the recommendations have to do with training. For example, this past year, there were several near fatality reviews that were related to adolescents with juvenile diabetes and management of diabetes, and or mismanagement of that diabetes led to a critical incident that landed the child in a hospital and a near fatality review. So some of those reviews said, you know what, maybe the department should include training on juvenile diabetes to caseworkers or have that available. The majority of the recommendations have to do with improved casework practice. That can be everything from assessment tools that are used, and about 12% have to do with partnering with community professionals. Then, so this slide breaks it down into a little bit more detail, about what each of those kind of subject areas or topic areas would include. And the number of recommendations made from each of those. And then this shows the implementation status for those topic areas. So again, 43% of the recommendations related to training were implemented, and another 24% were in progress. Similarly, casework practice, about 32% were implemented, and about 7% were in progress, and about 43% were considered but not implemented. Partnership with community professionals, again, almost 80% were either implemented or in progress. So we see a kind of a variation based on the topic type in relation to whether or not the department determined it was able to implement the recommendation, or if the department concluded that yes, this is not a recommendation that is simply unique to one particular case, but really has broader implications that should be implemented on a statewide basis. So the next few slides, I wanted to kind of before I move forward, I want to point out that our report includes a verbatim description of each of the recommendations that were made in the executive near fatality and fatality review. So all of those recommendations are contained in our report verbatim, as well as the implementation status, and if it was not implemented, the explanation that we received why it was not implemented. And so I won't go through in my presentation today all 124 of those recommendations, but I did want to highlight just a few that kind of struck me as being exceptionally noteworthy. The first one I already alluded to, and that is diabetes management and care and consequences. So there was a recommendation around training around juvenile diabetes, and the department's response was that statewide information is available, as well as diabetes training through the Alliance, which is the partnership between the University of Washington School of Social Work and the Department of Children, Youth, and Families. And similarly, that in a specific region in Pierce County, Mary Bridge Hospital provides a diabetes 101 training to DCYF staff. I also already mentioned suicide prevention, and that there has been a suicide that was attributed to neglect and that received an executive review. And the department's response regarding that recommendation was that statewide suicide awareness training was included in an annual training for all DCYF staff. As far as practice consultation, so this is an issue that's come up for the past several years at least, and that is the recommendations that the department should have a DCYF employee with expertise in substance use disorder in every office, and that individual would be able to provide case consultation and advice on case management when a caseworker is dealing with a case involving substance abuse issues. And for years, the department responded, yeah, we don't disagree, that would be good, but we do not have the budget to hire a staff in every office to fill that position. So what I think is noteworthy that I think the department looked at that and said, okay, is there something else that we can do to kind of address that need? And the department created a substance use disorder program, a full-time position for a substance use disorder program manager position. And that person would be able to provide expertise to staff on areas of substance abuse.
Patrick, can I ask you a question?
Yes.
So on this topic, is that individual also able to provide support to caregivers who may be caring for youth who are struggling with substance abuse and help them develop the skills they need? I think it can correlate somewhat with the suicidality. Like, are we equipping caregivers who are caring for teens who may be struggling with those dual things? Can that individual also provide that support to those caregivers?
I think that would be better answered by Secretary Hunter, but let me jump in with my best guess. And I think that would be indirectly. So through the caseworker would have the direct access to the program specialist, but the foster parent or relative caregiver, kinship caregiver wouldn't necessarily be able to contact the program manager directly. Is that correct?
That's correct. I actually like to amplify that a little bit. Every single child in the foster care system is enrolled in Core Connections, which is the healthcare program that provides a very enhanced care coordination work with coordinated care with our healthcare provider. And I would hope that we would be able to get that kind of care coordination for a child who has a substance use disorder through the healthcare system. Because honestly, I think it's likely to work better if it comes from the healthcare system than if it comes from the man, and which is kind of us. And we're happy to provide expertise, typically indirectly, as actually the one person statewide to do this is a licensed, there's some licensing for it. But this really is a healthcare issue, and can we get effective treatment for every single kid? A kid needs to be involved in treatment, and it is one of the biggest challenges in this state in the behavioral health system for everyone, not just for kids in foster care. But can we get effective, ideally evidence-based treatment for kids and get them resources to actually help them and help their caregivers work through what needs to happen? In this case, an astounding fraction of the teens who've been in care for a period of time have a substance use disorder challenge. So one person is not going to be a direct resource for that, but an indirect one, and our healthcare system should be providing that.
Thank you. So the next recommendation has to do with critical incidents and what happens when there's a child fatality that occurs. And one of the recommendations, this is a recommendation that has come up in several different reviews, and that is that the department establish a protocol similar to those used by law enforcement agencies with that, so that when there's a child fatality on a caseworker's caseload, that they are relieved from the new case responsibilities, and that there should be some sort of formal response. The department does have a kind of peer support kind of program, but this would be kind of another level. And look at like what law enforcement does to relieve an officer when there's a critical incident of their duties, and also both to protect the caseworker and also the families that caseworker might be working with. So for example, if I'm a caseworker and I just had this child fatality on my caseworker, is that going to have an impact on the way I engage with the family tomorrow or next week? And so that was the general recommendation, and that has not been specifically implemented. as noted in the slide, that there was a House bill in 2020 that would have allocated additional staff to meet that need and provide temporary relief to cover caseloads. But that was removed from the bill before its final passage. So some of these recommendations, they need some legislative approval. They also require additional, they have budgetary impact, et cetera. So it's not simply a question of the department implementing or not implementing. The department did create a full-time peer support administrator position to kind of help address this. So this is another situation similar to the recommendation that you should have a substance abuse expert in every office to do case consultation, and the department determined, well, we can't quite do that, but here's something that we can do. And similarly with the critical incident response, the department determined, well, we can't fully implement this recommendation, but are there some other things that we can do to help address this need? This is a recommendation that I would imagine will come up in future reviews as well. So again, a lot of the cultural and ethnic issues are, frequently come up in these reviews. It could be a family. There could be language issues, cultural issues that may add a different dimension to the department's ability to engage with the parents and extended family. And these reviews have recommended that the department partner with culturally relevant groups and develop resources for DCYF staff, both to provide education and support to the caseworkers on engaging families, as well as making sure that those workers are aware of community resources that are culturally appropriate for an individual family. And that's a recommendation that was implemented statewide. Collaboration with the court system. And I've tried to also kind of pick out recommendations that kind of come up on a regular basis. And this recommendation about collaboration with the court system, and it's really broader than the court system. It also includes collaboration with parents' attorneys, collaboration with the Office of the Attorney General, the CASA, court-appointed special advocates and guardian ad litem programs, better coordination with judges and commissioners and the court calendars. It can also, so sometimes a review will identify overly contentious or combative environments in certain local court systems that have an adverse impact on these cases. And are there ways to understanding that the court system by its nature is a resource to litigate and to advocate for individuals' best, stated interests, and that there's a level of conflict that's inherent in that, but that it needs to be done and maintained in a professional manner that does not have an adverse impact on managing these cases. So that was kind of the focus of some of these different recommendations of improving a more collaborative interaction within the court process.
So you have stated there it was implemented in that region, so it was not implemented statewide, it just by region.
Yeah, that was one. I think I know which. I hesitate to say in a public forum which county that was, but it was identified as being a particular issue in one county as opposed to other areas. And then a recommendation regarding near fatalities, that we do see more and more cases in near fatalities where a life-saving measure of Narcan was used. And ensuring that those are included in the cases that qualify for a near fatality review. And that is in progress. And it also would intersect with the current RCW requirement for when a physician determines that, but for medical intervention, that it would have been a fatality. So, it's in progress, but I think that's something that is noteworthy. I think we will see more of those, unfortunately, with prevalence of drugs like fentanyl and other opioids in our community, as well as, the positive side effect of the availability of Narcan. And so fortunately, we are seeing that those are near fatalities and not fatalities.
So how are they reported now?
So it, I would have to, let's see if I have it in my notes. The RCW kind of defines what a near fatality is, and it's a physician determining that, I don't have the exact language, but for medical intervention, a fatality would have resulted. And so there might be a report to CPS, and that specific language might be missing in the review, but it might report that, this child ingested fentanyl, overdose, was administered Narcan, and recovered. And so those are, a recommendation was that those should be included in the cases that qualify for a near fatality review.
So just let's say a young person overdoses on fentanyl and then they're given Narcan. But would that also be looked at as a possible suicide attempt? I'm just throwing it out there because I'm just wondering. So
that's a good point. So that the
I can't answer that question. I don't think you can either.
Yeah.
this is the first time I've stuck
I don't
both
know
these
how to
guys
map.
at the same time, okay?
Like, this is a small number of cases compared to the total number of cases in the system, and how they get coded. I don't even know who codes them in this particular scenario is pretty interesting. Each one of these cases, though, these near fatality cases, gets looked at individually. And it's not like we're just wading through a mass of statistics. I mean, like, we talk about these deaths and near deaths, but so do they code them that way? I don't know. I think you'd have to just, I don't even know how you'd figure that out, right? You can't say that every overdose is a suicide attempt, because we get a whole bunch of little babies who ingest drugs, and they're clearly not trying to commit suicide. And so that's a judgment call somebody's got to make in there. And we can go look at that. I don't know how to. We got to go look at the stats on how we do that. And that's a good question. I'll look. I have no idea how to do that now.
Thank you.
All right. Well, before I jump into question and answers, I wanted to make one other comment, and that has to do with the structure of the fatality reviews. And I kind of tried to describe that earlier in my presentation. In 2021, the Department of Children, Youth, and Families joined a national partnership for child safety with the goal of implementing safety science in the executive child fatality reviews and standardizing the process for these reviews. So one example would be using a system mapping when conducting the reviews and identifying specific issues in a critical incident, in a child fatality, and determining whether a recommendation is a local level, whether it's something that should be addressed at a regional level, or even if it's something that needs to be addressed through the legislature. And so doing this in a more of a standardized analytical kind of process of mapping, what was the root cause, or what were related issues, and what are the recommendation, and who would be responsible for implementing that recommendation? Again, is it a local office? Is it something that need to be addressed at an executive or legislative level? And then the third piece to this partnership is data sharing among states. And I'm not sure where we're at with that data sharing. I think the states are in the process of working out data sharing agreements. But the goal is that, Washington State might do, 37 child fatality reviews, and we have a small pool. And it might be hard to determine, well, is this a systemic issue that needs to be addressed, or is this just a cluster of cases where this issue came up? Data sharing among states obviously would allow states to share that information, and Washington say, yes, we're seeing this in Washington. We're seeing an increase of infants and toddlers ingesting illegal substances, and that same issue is prevalent all over the country. Or maybe it's not, but we'd be able to share that information, share recommendations, share implementation strategies. So I think that is, I think that's encouraging. I think it's a positive step, and I'm open for questions.
Good. Thank you for an excellent overview of your report. So questions from the board? I can see a hand, but I can't see who it is.
Justice Bridge?
Yes, thank you. Can you hear me all right?
Yes.
I want to go back to, well, I guess I'll make a comment first, and that is on the issue of collaborations between courts and justice system involved folks, attorneys, CASAs, et cetera. I think I want to just put an exclamation point on that. I think it's an ongoing issue, and it has been for 30 years. And it doesn't just relate to death or near-death incidents. And I would encourage more consideration on that issue. But with respect to today's topic, though, I want to go back to the issue, not the issue, but the recommendations regarding trainings. And I guess I would include both the discussion about diabetes type 1 as well as youth suicides. But I think it's, but youth suicide, since it sounds to me like arguably more kids involved, maybe I'll just use that as the example, even though I think it might apply to diabetes. And that is that, Patrick, one of the things that you said, and I think it was part of an exchange with the secretary, but about training with respect to staff to do screening at the beginning. Now where I'm on the suicide part, prevention, screening and beginnings at the beginning of care. And then periodically thereafter, but also education for caregivers so that they are aware of the warning signs and other resources and things like that. And one of the things the secretary said had kind of confused me in a way, and not so much in another way, Ross, when you said that, maybe that stuff is really important, but maybe the messenger ought to be public health. Or health providers, and I totally get that. But I am concerned about not really addressing, we talked about staff more, but about addressing the caregiver. And I don't think we should necessarily depend upon the social workers to educate the caregivers. What is the department's responsibility in facilitating, if not giving, that kind of training to the caregivers? Because as I said, particularly with suicide prevention, but not exclusively. I mean, it can go into trafficking prevention. It can go into type 1 diabetes. And so how do we make sure that that is happening? Including the caregivers, that is to say.
Representative Dan,
Yes, sir.
Justice just asked a question. I know your schedule has me on the schedule at the end to answer questions, which I'm happy to do, or I can do it live. But I think that's a question for me and not for Patrick.
Yeah. I think-
However you want to handle that.
Well, I guess maybe the question to Patrick is, I mean, he said what he said, and about including, at least with respect to suicide, incorporating, doing this training, but then also making sure that the caregivers are given training about it. And I got the impression that, well, that's supposed to come from healthcare authority or somebody. And how do we get that? How do we get that recommendation otherwise?
Thank you, Justice Bridge. Let me see if I can clarify what I said. There's always the risk of having a non-social worker answer these questions that I just mangle stuff terribly. But I was responding to a question about substance use disorder treatment for an individual youth who has a clear substance use disorder problem. And I would like that treatment to happen from the medical system, because I think it's likely to be most effective, and because we're paying for it. Seems like that's what we ought to get since we're paying Medicaid for it. The suicidality is not what I spoke to before, and I think it's a real issue. We do a screen for every child coming in. We do the GAIN-SS, which is a standardized health screen for every child coming into care. The recommendation is that we periodically do a screen that involves questions about suicidality. When we look at, we're doing a review of all of our assessments because many of them are, words fail me, inadequate at best. The GAIN-SS work, we looked at what we actually saw. And when we look at challenges that come out of that assessment, and again, it's a short assessment. This is not a detailed mental health assessment. We get
A screener, yeah, screening, right.
Screening, right? But we get a suicide item indicated in between 20 and 25% of the cases for youth aged 13 through 17. And what, interestingly, suicide, when we split that by the placement type, if they're placed with a relative, that's 19.4. If they're placed with a non-relative foster care, it's 25.8. So it's another scenario where relative placements result in better outcomes. We are intending to figure out a way to have an assessment that we can do regularly, but one that has an evidence base behind it. And that's part of our assessment redesign effort, which is underway right now. So I don't have like details on exactly what that assessment will be. We would like to use a standardized, one where there's evidence in the literature about what works and what doesn't work. I'm not sure that we're going to get to that. We may need to develop one which is more painful. But that we'd be happy to come talk about the assessment redesign work here if people are interested in doing that, because it covers the entire spectrum of children that we serve across JR and across foster care. So it's a concern. We do screen. We screen on intake. We don't do regular screening. As our percentage of placements with relatives goes up, typical relative placement scenario is we get a kid, we find a relative within 72 hours, and we place the child there, and we have not done 30 days of training with that particular caregiver. Our relative placement rate is up to 53% as of Monday, which is up from 44 where it was when we started. We're excited about that. We clearly want to make that information available, particularly in cases where we have teens in care. We'll come back with how we're going to do that. But we also can, as with all training, we can kill people with good intentions. If we, there's a maximum amount of training that people can absorb. And if you ask people to do more training than that, they will forget some part of it. And the challenge is that they will forget the part that you probably wanted them to remember, and they will remember some weird salacious training that you gave them that doesn't come up very often. So we want to tune that very carefully of what's required and what's offered, and what's offered in specific cases where we have a specific concern with a particular placement. So we want to get training in front of caregivers for kids, both youth who are at home as well as youth who are in our care. Clearly, we have a deeper responsibility when children are in our care.
Thanks, I appreciate it.
Thank you, Ross. And so before we move on, if we could direct our questions here towards Patrick for his presentation, and we will have a shot at the secretary after our break. He's going to have a presentation, and then anything is directly related to Ross, I'd appreciate if we asked them later. So I don't know who put their hand up first, so I'll just go with Dr. Levy.
Thank you. I had two questions. The first one was about your suggestions and recommendations and how you follow those over time to make sure that when you've made a recommendation and it's been implemented, it's actually leading to a successful outcome versus one that's has possibly been implemented and then maybe is not making much of a difference. Are you tracking those things over time to see if they are truly successful? So I'll stop there and let you answer that one, and then I have one more.
Thank you. Not in a quantitative way, but rather we are certainly kind of aware of the major recommendations that are made and how they're implemented. You know, so a good example would be that I go back to infant safe sleep and some of the things that the department has done in response to that, as far as you know, reviewing safe sleep practices and period of purple cry in every CPS case when they first engage a family with an infant. Similarly, following that practice if a child is placed with a relative, and then periodically during, for example, health and safety visits, saying I'd like observing the sleep environment for the child. So we are able to kind of track that both through our involvement in child fatality reviews and then just the complaint investigations that we receive. So our office receives a complaint from a parent that is, the complaint issue is, I'm complying with services and the department isn't making efforts to, you know, return my child. We're reviewing that, but we're also reviewing the health and safety visits and saying, oh, well, the worker is going out to see the caregiver, and during the health and safety visit, whether or not they're doing the safe sleep environment, you know, observation. And so we're able to kind of track it in that way. But I think your question, Diane, went more to whether or not we're doing it in a more of a systemic way, and we just don't have the bandwidth to do that.
Well, it seems to me like that's kind of where we really should be going, right? We have to know that when we make a recommendation, it is actually leading to a successful outcome and we're seeing the reduction of the risk that we intend. I mean, at least in that makes sense in my brain. And I also think there are times where they aren't acting on your suggestions, right? Your and recommendations. And then the question is, maybe we should have acted on that, right? And so maybe we need to go back and make that suggestion again. So I would just lobby for some sort of more of a, higher level kind of following of that various trends related to your recommendations.
The other piece to that is just because a recommendation is made in one review in say like 2019 and the department says, no, we're not going to implement this, for whatever reason. If it's a systemic issue, that same recommendation by a completely different review team comes up again. And we see that. And I know DCYF administration recognizes that too. It's like, okay, wow, in reviewing these recommendations over the last X number of years, this is something that keeps coming up again and again. So there is a level of accountability kind of within the review process.
Okay, thank you. My other question is, in medicine, we think about sort of mortality and then morbidities, right? Like, so you're talking about fatalities and near fatalities. My question is, do you also follow maybe more non-fatal outcomes? For example, we see a lot in medicine, we see a lot of kids who are bouncing back and forth between parents and foster care and the morbidities that they suffer with PTSD and those types of things. Do you track any of that piece of things at all? Like kids who've maybe been in and out of, foster care multiple times or placements multiple times, anything like that?
No. So we again, I go back to these administrative incident reports that we receive that document the fatalities and the near fatalities. And that's kind of what we're able to kind of review and assess. And we don't, we're not necessarily notified of situations that do not, I guess, qualify or fall into that reporting system for fatality and near fatalities.
Thank you.
Yes, you can do that. Okay, Senator Wilson.
Thank you so much. And you may or may not have a response. So I'm just going to ask a couple questions and it may be worthy of a follow-up later because I am absorbing everything I've heard. But I want to go back to the youth suicide. And number one, I want to make sure that you're talking about youth that are currently in state care or involved in that. So when we're looking at your statistics, we're looking at that particular group of young people. And wondering as we think about extended foster care and over the last couple years been able to expand that, and as we think forward, I'm going to make an assumption that those would also be things we would continue to track is even young people who are outside the current range. And I think I see you nod your head, so that may be yes. So you would really follow and track any age that we would put within legislation as far as young people in care is what I'm
correct
thinking. Okay,
so,
okay. And so I guess I'm thinking about the demographics, and in particular, I'm interested in protected classes. And as we think about young people, and as we think about suicide and self-harm and ideation, I think about supportive and appropriate family placements for young people, and just curious about how it is we assess, or how is it we perhaps gather the information to make sure that places where young people are placed are supportive. I don't know if that's making sense or not, as we look at assessments, whether it's upon entry or whether it's ongoing. I know sometimes that's an issue for young people and an issue for families, and especially if a young person is struggling with sexual orientation. I'm going to put that out there. And so I'm just wondering about how we reflect back then and how that may be informing our work. So not only about suicide and what ideation looks like and what those risk factors might be, but also about how families are interacting and how we're sharing information with families about adolescents and what adolescents are going through. Because I think it is a struggle for some families to understand, and I would say families in foster care might be the same. And then I'm also just wondering if there's any tracking of the kinds of services, or if there were any services or resources young people who were receiving while they were in care, and is there anything we need to think back on that might be universal that we should be just providing young people while they're coming in, before we find out too late that there are some things that we should providing all youth. And I'll kind of stop there, but I just am just curious about the preventative nature of the young people and about the work we could and should be doing as we think about what the outcome of your presentation is today, and as we think about the young people we've lost. So thanks.
Thank you, Senator. And again, this is kind of one reason why I wanted to focus on youth suicide and attempted suicide in this report, because we see it in the AIRS reports, but they don't qualify for the executive reviews. So there's really not that opportunity in each of these cases to, delve into like, well, what services were offered and what were the placement decisions, and was the placement supportive, or are there other supports that could have been in place, or were there risk factors that we missed? And that's, again, because of the legal structure in federal and state law around what cases can qualify for a review, which would allow, disclosure of and sharing of confidential information. With that said, and that's why kind of the recommendations, and they're very general in the report. For example, develop and implement a screening tool. So, and I think that could not only identify is this child or youth at risk, but also, what type of placement is most supportive and suitable for the child, right? So I think there are different ways that screening tool kind of could be used. I think, and the department is doing things. For example, we already have suitable adult placements so that the court can approve a placement that might not fit under relative or licensed care, and the department is licensing individuals for a child only kind of license to try to kind of fit that need to identify what placement is going to be the best and supportive for this child.
Thank you.
Thank you, Patrick. Ben, you have a question?
I do. I apologize for not having my video on. I have an unstable connection this morning, and I keep freezing up. So apologize for that. Good morning, Patrick. I do have a question. You made the point earlier on that some of the risk factors that are associated with these cases are also associated with cases in general that come to the attention of CPS. Are there any distinctions that you can make around the fatal cases or the life-threatening injury cases that look different than the normal risk factors associated with all cases coming to the agency's attention?
Not really. And I guess that's unfortunate. If there was one kind of distinction, then I think that would help us prevent these fatalities and near fatalities.
Well, yeah, I definitely agree. That's one of the big challenges. It seems to me that some of the other studies that have been done have really attempted to think about the cases that aren't reported as well. Have you done any thinking about the underreporting, particularly in areas where neglect cases are confused with accidents, like drownings, gunshot victims, and so forth? Are any estimates of those cases that may or may not have been referred or included in your reviews?
So those are cases that, again, we are not notified of. And I'm sure that data is available through different sources. But a quick answer, Ben, is no, I have not I haven't implemented or incorporated that data with kind of our pool of cases that are kind of reported that are directly related to abuse or neglect or involve a family that had prior involvement with the department.
Yeah, I see. And one of the groups that took a look at this was the National Commission. I think you may have seen their report. David Sanders from Casey Family Programs was the chair of that group. And they pointed to the fact that there are significant underreporting, mostly because of differences in definitions and so forth. And some have tried to use ICD-9 codes, which are injury-related codes for hospital admissions, to get an idea of what the underreporting could be. And I was just wondering if you think that might be a good thing to think about as we go forward.
Ben, I don't have a quick answer to that. I know that reporting and mandated reporting requirements can be somewhat, controversial, and raises the, I guess, the concern that, are we profiling individuals? Are we unnecessarily including families in CPS investigations or involvement for reasons that are not related to abuse or neglect? So I don't. I guess I'm talking around your question, and I don't have a specific answer, Ben.
Well, that's why it's a very complicated situation, and I appreciate that. And my apologies for my dogs barking in the background as well. I didn't hit the mute button fast enough. Thanks, Patrick. Appreciate it.
Thanks, Ben. Lonnie, you have a question?
I do. Thank you, Representative Dent. Hi, Patrick. Thank you for doing all of this data. You and your team are really helping us out here to try and find some solutions, and for, it's helpful to DCYF as well. One of the things that I found myself feeling as I was hearing this presentation is my natural human reaction to want to point a finger at someone or something. And, but what I'm wanting it to do is lead me toward finding specific solutions. And I see that the circumstances around a child's death is so complicated and seems multifaceted. But in your data, did you find a number one reason a child passed and whose care that group was in? So I'm trying to think, is there a specific focus of training or, social work practice or something? I'm trying to grab onto something a little more solid, if that makes sense.
Lonnie, I think my quick answer would be all of these kind of cases are unique. Okay. I think there are some that, and I'll go back to sleep environment, and you know, I also have that similar reaction of wanting to, you know, point a finger of blame. You know, there's
Yeah.
that kind of visceral reaction, because these are preventable.
Right.
And it is when you kind of sit on one review after another, and they all involve with an infant's death related to unsafe sleep practices, and that is so preventable. You know, I'm not sure what the next step is. You know, I think you know, again, I'm impressed when I'm reviewing cases and I see, you know, workers diligently reviewing sleep environments and going documenting that they reviewed safe sleep practices. But I think the challenge is a lot of that is it's generational too.
Right.
You know, and families feel like we've always done this and nothing bad has happened. So, and that's human nature.
Yeah.
You know, there are some other situations that kind of come up again. You know, I alluded to, we're seeing more fatalities and near fatalities related to, you know, mobile infants and toddlers ingesting drugs. And I think that is related to kind of the prevalence of opioids and fentanyl. And so maybe similarly, we will need to craft some sort of both public health and DCYF specific response to engaging families and caregivers with, I don't know, secure methods of you know, storing drugs to prevent accidental ingestion, but aside from that, there's also a lot of, you know, there's not one thing, and every case is a little bit different.
Okay, that makes sense as an answer. And what I'm seeing from this report really over and over again, the number one theme is everyone needs support. We need more support and training for our caseworkers. We need more support and training for our foster parents, support and training for our parents, you know, when we're trying to reunify with the kids. So I guess maybe that's my number one takeaway for now, is just somehow finding those specific reports and evolving, like you're saying, with these new unfortunate substance abuse trends. Fentanyl is going up. And I mean, just as an example, Jamestown Tribe, we just opened up our own medication assisted treatment center, and we can't keep people in the programs because by law, the dose of methadone that we can give does not cover the craving that fentanyl from the streets now puts in people's systems. So it's really hard to keep our people into these programs. And I'm sure that trend is happening everywhere else, and it makes it very difficult and therefore more open for children to actually accidentally ingest. So makes sense. So thank you. Thank you for your answer.
Thank you.
Thank you, Lonnie. Ruth, do you have a question? And we're approaching our break time, so if we could make it a concise question, I would appreciate that.
I will do my best. Thank you very much, Representative Dent. Well, first, I was struck by the decrease in the number of sleep deaths related. The department has taken a very focused campaign to reduce infant deaths, and it's obviously had a real impact. So I think it's a real testament to the power of focused policy and focused training, and really trying to reduce infant fatalities due to sleep, you know, unsafe sleep situations. But the other piece, Patrick, that I really am interested in your thoughts, the percentage of fatalities related to neglect appear to have increased pretty significantly just in this last year. And I know 1 year isn't enough to indicate a trend. But I'm also aware that there is a new standard for removal of a child, which requires imminent danger of harm. So I'm just wondering if you have any concern about the policy neglect, that policy, and whether children will not be removed when they are in neglectful situations, and that neglect is resulting in more deaths.
And I think that it gets at the core of the competing policy goals of our child welfare system. With on one hand, child protection, and on the other hand, supporting families and reuniting families. And I think the child welfare system is in the unenviable position of pursuing kind of both of those goals, and is subject to criticism on both ends. From CPS needs to be torn down, and because we're destroying families, and then on the other hand, children are dying because the department isn't intervening. Personally, I think the best approach is kind of a long-term effort to, like, how do we address poverty? I mean, I think it really goes to those larger questions. How do we support families? How do we keep families out of homelessness? How do we ensure mental health supports are widely available? How do we address child safety issues before there's even a report to CPS of abuse or neglect? But I agree that there's a danger if the pendulum swings to we need to dismantle CPS, that or if we set a standard that is too high before the department can intervene or before law enforcement can intervene, then the result is very likely to be an increase in child fatalities, specifically those related to neglect.
Okay, well, I'm hopeful that you will keep your eye on that moving forward of, how fatalities through neglect relate to policy. Thank you.
Thank you.
Thank you, Ruth. That was an excellent question. Appreciate that. So we have a couple of minutes. Are there any further short, concise questions from the board? If not, I'm going to ask a question, Patrick. If we can't do it quickly, then we can talk offline. But in the very beginning of your report, you were talking about the fatalities and the age group of the fatalities. Okay, and it struck me that we had, a higher number than I would expect in the age group from 13 to 17. I can understand the infant fatalities and abuse fatalities. I don't understand why they happen, but I understand how they can happen. But I kind of struggle with how a fatality would happen to an individual who is now basically a teenager, basically moving into adulthood. Is there any nexus there as far as the type of abuse that caused this fatality?
I want to clarify in the report. I'm not sure what I want to.
We can talk during the break.
Yeah,
We can do that.
so my quick guess is that I want to confirm is I'm not sure if those are all related to abuse or neglect, or if some of them might be related to accidents or dangerous behavior. And I'd also note that it's, again, we're talking about a small sample size. So of those 3 years, we're looking at 1 in 2019, 4 in 2020, and 3 in 2021. So.
Okay. Very good. Thank you. Appreciate that. So we'll take a break and we'll come back in 13 minutes or so, 15 minutes. We have two public comments moments, so we'll come back in 15 minutes. Thank you, everyone.
Thank you.
So lots of questions for Patrick about.
Are we
You're not on mute.
Well, welcome back, everyone. We'll get started here with public comment, and for the public comment portion, Sharonda will facilitate. Sharonda?
Thank you so much, Representative Dent. I'm going to just start off by just reading our statement, which states that the DCYF Oversight Board is governed by state law. Per state law, the Oversight Board's authority includes monitoring DCYF's achievements of 8 outcome measures listed in the DCYF's founding legislation, monitoring DCYF's compliance with applicable laws and policies pertaining to early learning, juvenile rehabilitation, juvenile justice, and children and family services. General oversight of DCYF's performance and policies, and providing advice and input to DCYF, the legislator, and the governor. The Oversight Board does not have authority to inquire into direct or change DCYF decision in individual cases. For those wishing to provide public comment to the board, we'd like to remind you that the board is subject to the Open Public Meetings Act, which means our meetings are open to the public and anyone can attend as an observer. Our meetings are recorded and posted on the Oversight Board's website and will be broadcasted on TVW. We wish to inform everyone in attendance of this fact as an act of respect and support to individuals who may have a sensitive story they wish to share or wish to express individual case details in this setting. The Oversight Board may use any information brought to the board's attention as it carries out its role of general oversight and monitoring of DCYF. Looks like currently we have 2 people that have signed up for public comment. And so I'm going to start off with Shayna Richard.
Okay, can you hear me?
Yes.
Okay, thank you. I'm asking to read my comment aloud today to share the story of Oakley Carlson with hope that you'll advocate to Governor Inslee for an immediate outside agency review that will provide transparency and impartial analysis of Oakley Carlson's Washington DCYF case. I'm a founding member of an organization called Light the Way Missing Persons Advocacy Project. Our team members have been investigating and advocating for Oakley Carlson, the missing 5-year-old child from Oakville, Washington. We are working with Oakley's loving and courageous foster parents, Jamie Jo and Eric Hiles, to find answers for Oakley, whose last known credible sighting was February 10th, 2021. Sadly, she was not discovered to be missing until 10 months later. Since February 10th, 2022, Light the Way has organized a weekly phone call and email campaign of Oakley's online supporters to contact Governor Inslee's office to ask that he conduct an outside agency review of our case and express our concerns about what happened to Oakley. For many months, we received no response from the governor's office. In fact, he even failed to mention Oakley's name publicly for months. However, at the end of July 22, our organization received an email from Governor Inslee's general counsel with an attached letter from the governor to Patrick Dowd, director of the Office of Family and Children's Ombuds. The letter dated May 27th, 2022 stated, "I believe it is prudent and appropriate to request an examination of the agency's handling of this case, whether to affirm that DCYF followed all proper protocols and procedures, or to identify whether agency actions may have contributed to her disappearance. Once you have completed your analysis, my expectation is that you will report back with your findings and any recommendations." On that same day, May 27th, 2022, Jamie Jo Hiles also received a phone call from Mr. Dowd. He let her know that he would be doing an investigation into her complaint that she filed with the Ombudsman's office in February 2022. He never mentioned that Governor Inslee had requested a review of Oakley's DCYF case. He told Jamie Jo multiple times during that phone call, "I cannot tell you anything, but you should tell me everything you know." He asked to see records of where DCYF messed up. The lack of transparency is abhorrent. Jamie Jo is a grieving parent that has been advocating for months to have her child be recognized by the state of Washington. The fact that Mr. Dowd did not mention that Governor Inslee himself had also requested the review shows that his office is untrustworthy and has us questioning if he is there for the best interests of families. Mr. Dowd had a second chance to let Jamie Jo know that about Governor Inslee's request for a review when he called her on June 24th, 2022. But again, he failed to mention that he is also conducting an investigation for the governor's office, and he continued to ask questions under what feels like a false pretense. He again repeatedly told Jamie Jo, "I cannot tell you anything, but you should tell me everything you know." We are concerned that Mr. Dowd may not be working in Oakley's best interest and question his ability to remain impartial. What happens if information is found that Washington DCYF is at fault and the agency did not follow proper protocols or procedures? According to the privacy laws that Washington DCYF continues to hide behind, no one would know. We want the board to understand that Oakley was failed. Here is one of the many examples of how Washington DCYF did not take those concerns seriously. On October 26, 2019, Oakley returned to the Hiles from a weekend visit with her biological parents. She stated that there was violence between Jordan Bowers and Andrew Carlson, who both had a history of domestic abuse. Oakley stated that she saw Bowers hit Carlson over a video that Oakley was watching on one of their phones. Jamie Jo emailed the social worker and was told that there were no concerns and that Oakley loved her mom and dad. This was one of the many red flags and warning sign that was ignored by Washington DCYF. And this was a pattern repeated over and over again by the social worker. Oakley Carlson was taken from a safe and loving foster home and left in a home with child abuse, drug use, and what ultimately ended in a devastating story of a missing child. If Washington DCYF focused less on meeting reunification statistics and more on the best interest of children, Oakley might be here right now. I imagine that she would be starting kindergarten and Jamie Jo and Eric Hiles, the two parents who love her most in this world, would be beaming with pride. Please help us in advocating for immediate outside review of Oakley Carlson's Washington DCYF case, where there can be impartiality and transparency in finding justice for Oakley. Thank you, Shana Richard.
Thank you so much, Ms. Richard, for continuing to light the way for Oakley. We appreciate you bringing your concerns and your perspective to the board. The second person I have for public comment is Tate Nuzan.
Can you hear me? Hello?
Yes, I can. Yes, we can hear you.
Okay, perfect. Thank you. Thank you for giving me the opportunity to speak today on behalf of Light the Way. Forgive me if I stumble over my words. I'm really not great at public speaking. So I've heard a lot of good concerns and topics mentioned here today, and a lot of it has been really informative. A lot has also been very eye-opening. I've asked to read my comment aloud today to share the story of Oakley Carlson again, with hopes that you'll advocate to Governor Inslee for an immediate outside agency review that will provide transparency and an impartial analysis of Oakley's case. Also, with hopes that you'll please reconsider making changes to the reunification process. I'm sure most, if not all of you here today are familiar with Oakley's case. For those of you who don't, or who aren't, Oakley is a 5-year-old girl from Oakville, Washington, whose last known credible sighting was on February 10th, 2021, an entire year and a half ago now. Sadly, Oakley was not reported missing until 10 months later on December 6, 2021. Still today, her bio parents, Jordan Bowers and Andrew Carlson, refused to give any information on Oakley's whereabouts or what happened to her.
Both Jordan and Andrew were charged with 2 counts of endangerment with a controlled substance for exposing Oakley's 6-year-old sister and 2-year-old brother to methamphetamine earlier this year. Bowers pled guilty and was sentenced to 20 months in prison. She will walk free in just 4 months. This past March, Carlson pleaded guilty to the 2 counts of endangerment and was sentenced to 12 months. He now walks free just like you and I. Meanwhile, Oakley's still missing. I'd like you to imagine for just a moment that you have a 7-month-old child put into your care, a very small baby who doesn't walk, doesn't talk, brought into your home. The child lives with you until the age of 3. You've experienced her first steps, her first words, her first birthday, very possibly even her first teeth. You're the only parents that she's known for almost 3 years. She's grown into a bright, young, happy child, and your love for her is immeasurable. Then suddenly, after 3 amazing years, that child is allowed to start seeing her biological parents for visits. At the end of the day, or sometimes even the weekend, when she returns to you, she tells you of the traumatizing things she saw or heard while she was away. The Hiles, along with other community members, raised concerns several times about her care to Washington DCYF, both while she was in the Hiles' care and after visiting her bio parents, and after she was returned to them. They feel as though their concerns were not taken seriously and were simply ignored, myself included. We're all seeking answers for Oakley. The Hiles were the only parents Oakley knew for almost 3 years before being traumatically removed from their home and put into a home with people who she didn't know, people who didn't love or care for her, a home filled with drugs, abuse, and neglect, all while the Hiles were filing paperwork for adoption. Now Oakley is a missing child and quite possibly worse. I'm sharing this story with all of you here again today in hopes that meeting reunification statistics not be the ultimate goal of DCYF. I understand that in some cases, reunification is what is best, but this isn't the case for all children. It should be on a case-by-case basis. I understand that this takes time, but it's what's best for the children who are the future of Washington. Let's please find a way to keep this from happening to other children by reconsidering current reunification protocols. I'm asking you once again to please move forward with an immediate review of Oakley's case and take the first step to make changes for the better. And please, let's take time to look at circumstances when considering reunification. And please, when making decisions, do so with empathy. Thank you so much.
Thank you also, Ms. Tate, for coming in and forming the Oversight Board today. We appreciate your time. I believe that ends our public comment with 2 folks. I also want to let the public know that the board had received 3 written public comments, and these comments were shared with the Oversight Board on August 30th. These comments will be summarized and included in the board meeting minutes along with all other public comments. So that ends public comment. And we will move to our next agenda item, which is to hear from Secretary Hunter. So just want to welcome you, Secretary Hunter. I'm sorry I don't get to see you in person. It's been quite some time. But thank you so much for joining us today. We really appreciate you coming and being in front of the board. So I'll just turn it over to you.
Thank you. So I'm mostly here to answer questions about the report. I have a couple of slides, I believe.
Yes, we'll pull them up.
To go through, and I want to address something that came up in the last meeting, which we did virtually, and I have an answer for you. But I want to start off with actually, let's not go to the slides quite yet. Let people get distracted and they'll get sucked into it. A lot of questions for Mr. Dowd were questions that were, I think, interesting questions, right? There's like big statistical questions about, well, what would work best? Like, this is a big system, and how do you, when you look at a particular change that happened, how do you assess, did it actually work? And I don't think the Ombuds office is actually set up to do that project. The Ombuds office was set up to resolve problems in individual cases. So people complain. The Ombuds has full access to all of our computerized information, which is all that we have. You actually probably know how to run the computer system. I have not been trained in how to do that, so I choose not to. I ask people to summarize it for me because I'm not a social worker. And it's so a lot of the inference we saw today, which I think is really insightful, is from looking at several hundred instances of a particular thing that happened, or looking at the errors reports. You've pretty consistently excoriated us, and I think quite appropriately for the hotel stay challenge, and we have worked diligently to try and address that. Some progress, struggling, it's a frustrating problem that every single one of my peers across the country is experiencing. So the kinds of feedback that we can get from the Ombuds office is stuff that comes from, I'm looking at these particular cases, typically egregious problems. They're not the normal, like, oh, this worked out in 20 days kind of problem. It's why is this still a problem? Questions. He digs in, he does findings, we respond to those, we try and figure out, is there a systemic problem? He tells us when he thinks there's a systemic problem. You saw some analysis from that. What's not there, we got questions. Dr. Levy, you had questions for him. Senator Wilson, Dr. DeHaan also has access to all that data and does have an army of PhDs, it's my understanding, to go answer all of your questions. Sorry, I'm poking at you, Ben, but are really like, we did this thing. How would you infer from all of the data that is produced by the child welfare system, is it meeting the outcome goal that you have? And I think those are really interesting questions that either we, our research shop can help answer. Some of the external folks who have access to the information, University of Washington through Partners for Our Children, Chapin Hall at University of Chicago, or people who want to look at the national AFCARS data to try and draw comparisons between us and other states as, are we making progress in a particular direction? I would love to have an opportunity, if we want to take on those kind of, what are we trying to do and is it working questions that are looking at the system as a whole, I think are more appropriately asked of me than they are of Patrick. But the input we get from Patrick is also really valuable at like making this thing actually work. And I want to make sure that we do that right. Yeah, ask him all the questions you want, and he pokes at stuff and comes up with answers, and we don't tell him what to do, and pretty careful about not telling you what to do. And I value the external input from someone who really can see the data, which is not typical. We get a lot of input from people who have a very narrow slice of the system that they are looking at. He has access to the full system. So it's think about the question that you're asking, and is it an appropriate question for the ombuds? Is it appropriate for us? And sometimes he'll answer a question that I don't think he knows, but he does. Like, that's okay too, right? I want you to think about, are you putting him in a place where he can't particularly answer a question? One of the questions that came up last month when I was here, and I do appreciate being here in person. Thank you for doing this. This is yet another room, and the most common feature I've seen of these rooms now where we're having meetings is that there's a clock on the wall that is stopped at some point in the last 2 years because no one has come in here and changed the batteries in the clock because no one cares. Like, you have no idea how many clocks there are that just have no AA batteries. It's we'll have to get that one fixed. Was the question I was reporting on the decline in the number of children in out-of-home care. And I talked about how we paired that with a balancing indicator. And I think, Dr. Levy, I think you were the one, I don't remember exactly who it was, but I think it was you, said, hey, the next time you come with that data, can you show us the balancing indicator? And I can. So we have that, whoever's controlling my slides, it's one of the ones in the like 4 or 5 after the first 2.
After the first 2.
Yeah, it's in there.
Yeah.
Go the 4th slide. This is going. Nope, sorry, keep going. It's in here somewhere. Well, I'll go back up. Did I pick the wrong slide? Darn. Keep going up. This is intakes, entries. This is it. This is what I wanted. Yes, thank you. So I talked before about the long-term decline in the number of children in out-of-home care from 9,000 starting in 2018 till now. We're now under 6,500, which is a 29% reduction. And the balancing indicator that we use is reentry into care in the 12 months following exit. So if we made a bad decision and we sent someone home, for example, and the kid comes back into care, that would show in this particular indicator. It would show a year later because we look at that after. So it lags a little bit, but this is a long-term trend. It's not like we're reporting on a 1-year trend here. And so what you see here is an indicator that bounces around a little bit over that period of time, but it is actually pretty flat. There's no long-term trend in that balancing indicator. And we think this is the right one. We're happy to have a conversation with people. If there's a different indicator of looking at systemic safety in the system, so if we can reduce the number of children in care and maintain the same level of safety, then we're making some kind of Pareto optimal choices, statistical choices about doing that. You are seeing nationally the same kind of decline in children in out-of-home care. This is not unique to Washington. When we looked at that, we were a little ahead of that trend, and we started doing this before the pandemic. You can see the little gray line in the middle of the bar chart. That's where the pandemic occurred. So this was a trend that has been occurring before that. I am looking forward to a river of PhD theses that will come out over the next several years, looking at the time in the pandemic, particularly in the beginning of the pandemic. We expected a large increase in child abuse cases because we have more kids at home, more time, and we'd have more families under financial stress because everybody got laid off from all of the low-wage jobs. We're like, oh my goodness, there's going to be a tsunami. And there wasn't. And I'm curious as to why. Now, I ask my research staff why all the time, and Dr. Barr rolls her eyes and says, you cannot start asking these questions. Why? Because I can't, it's hard to get at them with just descriptive statistics. But I, like the elephant's child, have insatiable curiosity. So I will continue to ask the questions, and hopefully the level of research to answer a why question to get causality will be challenging around the country. But we believe that the financial support for many low-income families actually significantly reduced the financial stress and consequently actually reduced child abuse. So if you're interested in a way to reduce child abuse, reducing poverty is actually a really good strategy. These are big, broad strategies that sort of a different look at the system than what we saw earlier, looking at really bad outcome cases. This is looking at the overall structure. So I was trying to answer a question that came up last month, and we're happy to answer more specifically if people have those questions. But I'm here to answer your questions about this particular presentation. I don't really have a presentation. I had some slides because I have numbers that might be useful to people if they ask those questions, but you have no idea what people are going to ask. So I'm prepared for what I think you're going to ask.
We have several questions here, written questions asked. We can begin with
Why
those.
don't you start with us?
Okay. Given the long and thorough list of recommendations listed in the appendix of the OPCO critical incident report, can you tell the board how DCYF makes decisions on whether or not to adopt certain recommendations? I
can, actually. So when I took over the agency, there's a whole bunch of things you try and deal with. And I would get these fatality reports that I'd read, and I tell you, they're unbelievably depressing. And there'd be recommendations in their reports, and I always wonder, so like, what happens to these? And the answer is, well, sometimes something happens to them, and sometimes they didn't. And so I created a more formal process for considering the recommendations and making decisions about them. As you heard from the ombuds earlier, many, I might even say most of the recommendations in this report and that are in these fatality and near fatality reports are not in the causal chain of events leading to the fatality, in that they're not addressing the root cause of the particular fatality. And they may in fact be interesting and useful recommendations, but reading them, you're always wondering, well, how would that have fixed that? Like, how would that have caused this death to not occur? And there are very few cases where we get a particular, like, oh, that would have got it, right? So we have a staff group that considers the recommendations. Most of them are either training or practice recommendations, and we make a decision. You see many of them we choose to implement. Some we do not, because the recommendations are made by groups and they are looking at often people who are not deeply familiar with our practice, our standards of practice, and they make a recommendation. And we may have tried that in the past and said, well, that doesn't work, we're not going to do it. And I wanted a way to make a crisp decision and not just let it linger, like it's just sitting there. And we said, no, we're not going to do that one. Some of them are pending. And the reason that they're pending is because we have thousands of caseworkers, and we have to train the caseworkers. We have a contract with the Alliance for Child Welfare Excellence, I believe, to do training materials. We run a regular new employee orientations. We have required updates on training, and we cannot change the practice all of the time in little ways. So we will hold some changes until we make a larger change in that particular area. You will see, for example, in the next year, a significant number of changes to CPS practice, the investigations practice, because 11 months from now, is that right? No, 10 months from now, the standard for removal will change to imminent risk of physical harm, which is a more strict condition. It will leave out cases where we are very worried, but we have there's no imminent risk of physical harm to the child. As an anecdotal data point on that, Texas made that change at one point with no notice. The legislature did it and it took effect instantly, and they saw a 44% reduction in cases. We have done a couple of looks at that. We expect a reduction in the number of removals. Our estimates range from 10 to 25%. It's hard to tell. We'll see how judges behave, implying that standard across the state. But that's so that will cause some changes. A variety of Supreme Court decisions have changed our practice. We had one 2 weeks ago that will change our practice and how we work with non-custodial parents. In a way, I agree with the change, but nevertheless, it's a pretty significant change. The change from KW and how we deal with relative placements is striking. The changes in ICWA cases, both in the percentage of ICWA cases and the formal definition of what active efforts means will require changes in perhaps 27% of cases, up from about 6% of cases today. And we cannot do those changes individually and then try and roll it out to our caseworkers and expect them to actually understand and apply it consistently. So you'll see consistent changes in that training. So pending probably just means it's in the queue to get rolled out when we make the next big batch of changes in that particular area of practice. So I want to, we make a formal recommendation. I just had the meeting this week for this quarter. The team comes and presents to me. It includes our QA team. It includes our practice folks. It includes the field, our policy staff, and our risk management staff looking at this and saying, should we do this? Should we not do it? Do we think it will overall make the system function better or not? And we'll make some explicit decisions not to do some of the recommendations as a result of that. So we don't think it will improve the system.
Thank you. Next question. The majority of the recommendations listed in OPCO's report, over 58%, are about casework practice. Can you explain how the agency is assessing these recommendations and how they may or may not interplay with large-scale practice changes introduced through the legislative changes over the past couple of years?
I believe that is the answer I just gave. I was ahead of you.
Are you good with that?
Yeah.
Okay. Can you describe?
Hey, Representative Dent, I just wanted to make sure that we noted that Paul Smith is here, who is DCYF's incidents person. So we didn't give him an introduction when we introduced Secretary Hunter, and he may be answering questions. So I didn't want folks to be like, who is this guy?
Yeah.
Welcome, Paul.
Welcome, Paul.
Thanks for being here, Paul. We wish
Thank
you
you.
were here in the room. Can you describe what occurs during a safety check?
Yeah, health and safety check. I think you heard from the ombuds about what happens there. We're required to have our, for children who are dependent, we are required to have regular visits with the child where we meet with the child in person, in private, so that there isn't a chance of them being intimidated by someone else. We observe how the child appears developmentally, physically, emotionally, how members of the family respond to each other. We observe the family situation, the child's attachment to the parents, the home environment, including the sleep environment, which I think you heard Patrick looking at many of those reports and saying, well, yep, they looked at the sleep environment. When I read a summary in one of these cases, there was actually a pack and play there, which is one of the things we give these out like candy of, here's a place for your infant to sleep safely and how we do it with no, you don't want blankets and you know what, because they choke on you. So we do that. The worker discusses with verbal children whether they feel safe, their needs, their wants, progress. They ask about family time and sibling visits to make sure that those are happening from the child's point of view. They ask them about their connection with other family members, participation activities. They make sure that the worker knows how the child knows how to reach the worker. And the worker also has a requirement to visit with caregivers. There's a long series of requirements for these. There's a checklist that they're required to follow and they are required to document. And so there is reams of documentation on any of these cases where they've been in care for a long time. The notes, like the notes of FBI folks, are really important. The extemporaneous notes that they took at the time when they were doing it are really important, and they are often future evidence in cases. So,
okay. Thank you. How does DCYF determine if a child is safe in whatever environment they are being sent to?
okay, we have a safety framework that we use. And this would be one of the assessments that we do of walking through that. We can provide you a link to the, I've got a link here that I can read out, but I don't think it'll be helpful. But we can get you the information about what that actually looks like, how to assess safety threats. Again, I am not a social worker, so I'm not someone who can do that, but there's a formal safety threat assessment that looks at all sorts of issues about safety, physical safety. One of them is looking at the safe sleep environment, particularly for infants, particularly if they cannot yet roll over. But for very young children, the co-sleeping is very, very dangerous with people who have substance use issues and who might not notice that they rolled over on someone. So we have a system that does that, that we would be happy to share with people. I'm happy to come have training done here if people want to be trained in how to do safety threat assessment.
Okay. Over the past 3 years, the percentage of yearly fatalities that occur when a case was closed within the last 12 months has gone down. So fatalities still are occurring once a child is returned home. Can you explain what leads to the determination a child is safe returning home and when a case is closed? Does DCYF receive additional intake referrals on cases that have been closed? If so, what is the policy for handling those intake referrals?
Okay, let me answer the last part of that question first, which is, if we get intakes on children who've been, where the case has been closed. So in Washington, when a child is returned home, there's a 6-month period where the case remains open and regular safety visits occur. In most of those cases, particularly cases with substance use disorder, there'll be required urinalysis tests or whatever drug tests at the time to do that. Once the case is closed, though, that family is just like every other family. So we have legal rules about what kinds of intakes get screened in or don't get screened in. We get, pre-pandemic, we got 120,000 calls to the hotline a year, and we screen in typically around a third of them. We had a severe drop when children were no longer seeing teachers in particular. A less severe drop in actual removals because the yield, the number of referrals from the education system that result in removals is lower than that from medical professionals, as you might expect. I mean, that makes sense. You know, when a kid is seen in the hospital, there's often a problem. So when the safety threat is gone and the judge decides to release the dependency, right? Remember, we don't make that, we'll make a recommendation to the court, but the court will make their own determination. They'll look at all sorts of information. They may have a CASA, a guardian ad litem. The child may have an attorney, and the child may not, the child's stated wishes may not be to have the dependency removed. The judge will make a decision based on the information that they have. When that case is done, we treat them just like every other family. We have no extra legal, like CPS is not in your life for the rest of time, right? If it screens in, CPS will come to your door. But if it doesn't screen in, we will not.
Thank you. How does DCYF assess the mental health of youth in foster care, particularly regarding suicide prevention? Is DCYF planning to address a policy changes to better screen for and support youth who are at risk of suicide or have suicidal ideation?
We use, so we do an initial assessment on children when they come into care. It's called a CHET screen. And it's the Child Health and Education Tracking Program. And it is the goal here, and I'll make sure I get my comments right here. It's responsible for identifying each child's long-term needs at the placement. So we're trying to figure out what's this kid need, right? And I think the CHET screen has to happen within 30 days. A placement's done by, we have screeners that do this, not done by the caseworker. And those screeners directly ask youth about suicidality. Suicidality, okay, there's a new word. When completing the GAIN-SS, which is the formal screening tool that we use for youth that are 13 plus, where we see most of that risk. If the screen positive in that area, which they do in 20 to 25% of those cases, we go into much more depth, trying to assess the current risk. They try and figure out, does the kid have a plan? There's all sorts of risks here that are pretty severe risks. We train every single one of our employees, me included, on suicide risk assessment. I'm sure I've had that training in the last year because I have someone whose full-time job is to force me to take trainings. It seems there's a never-ending list of them, and I still have not 100% succeeded in passing the procurement, which is just like, it's weeks of training. And I just don't do procurements. So all that stuff's documented. We do it now. The recommendation Patrick makes is that we do this screen on a regular basis, or we do a screen. We don't do that. We did that analysis of looking at what we see in those assessments, like looking at the outcomes, and we see a suicide item in it's a very large number of teens coming into care. So if you're coming into care as a teenager, there's a lot of risk there. Less risk if you're placed with a relative than if you're placed with strangers. The thing that we really want to do in those cases, we want to get support in place. We want to get behavioral health support in place for those youth. That support is available. We have some that is available through our evidence-based programs, but a lot of it is really available directly from the healthcare system through coordinated care, through the Core Connections program, which has been a big improvement, getting all the kids on this care coordination model. So the job of the caseworker is to review that. The job of the caregiver is to review that, to make sure that we've got those services in place. Our staff are not behavioral health. They're not mental health specialists. So we can do screens, but we need kids that indicate positive on screen. We need them to see mental health professionals, and we need to make sure that that is happening. Our job is to make sure that's happening. So the mental health screeners re-administer mental health screenings. Caregiver and youth see that. I don't think we have a way statistically to look at that data yet, or at all. I'm not like walking through the medical privacy, attaching it to a particular child and with multiple providers all over the state, is a challenging analytical project. And I'm really interested in doing it because I'm worried about this. I'm worried about substance use disorder, and I'm worried about suicidality. And they're there's a lot of comorbidity. We don't want to do the whole Chet screen, but they would love to do it. But again, where's the right place to spend staffing money? We're engaged right now in a caseload analysis and staffing model analysis that you guys asked us to do last year, that we're really excited about. And what I want to do in this is I want to review where do we have staff. I'd like to maximize the number of case carrying staff, reduce the number of non-case carrying staff as a general strategy. But we got some people like screeners where we have really unique knowledge. Our substance use disorder coordinator, I don't want to lose that staff. We hired them on purpose. But to try and be intentional about what level of staff where, our staffing patterns are very different regionally. They vary a lot by region. And I personally would like to have it be more consistent statewide. And I expect the result of that study to help illuminate that, and we will have a discussion with the legislature about what we recommend when we look at the study, and then they'll determine what they decide they can afford. And you know, those budget people are really squirrely, right? They're actually all friends of mine. They all do really good work. We have really no complaints about the level of resource we've been getting lately. I just have to make some self-deprecating joke here about former budget chairs running agencies, but should we have more staff who do this screening, or should we just lower the caseload for caseworkers? I think that's a really interesting decision. We don't have infinite money. We don't want to have infinite money. I would like to particularly use the reduction in the caseload as a way to have our staff have lower caseloads, because that helps with retention. Retention helps with not changing caseworkers all the time in each individual case. And every time you change a caseworker on a case, it extends the case. And once you get more than 2 or 3 caseworkers on a case, it's pretty predictable that you don't get a permanent outcome for that case. Hard to do causality. So where should we best allocate our resources? That we think this study, we thank you for funding it. We're taking it quite seriously. Will give us a lot of information to jointly make decisions about what the appropriate staffing model is. It might include lots of screeners. That might be better to do more training of caseworkers and have them have a lower caseload. We'll find out.
So my concern that as you talked there about making your staffing across the state more consistent, but our state is so diverse. You know, I've struggled with why we'd want to make it more consistent when we are so diverse across the state. With, you know, I mean, we have rural areas, we have agriculture, we have manufacturing jobs. I mean, we have a lot of difference in how people work, how they make a living, and how they interact with each other. So why would you want to make the staffing levels more consistent?
I didn't say 100% consistent. Needless consistency is the hobgoblin of little minds. But I'd like to have our variance be intentional, right? And mostly our variance is historical. King County has a higher percentage of non-case carrying staff than other regions do. Why? Well, if there were a reason, I'd be, okay, we can have that discussion. If there isn't a reason, well, what do we do about that? And like, how do we think about having more consistency? Means that I don't have to invent a procedure 6 different times. It means that a judge who might hear a case from one that's handled by one region and a case that's handled by a different region, and says, wait a second, your practice is really different here. And so I'm going to throw out all these cases because they're not the way I'm used to it. Like, wait a minute, right? So I'd like us to be intentional. In Eastern Washington, things are much further apart. There might be some times when we could use virtual visits for some things better and not better. Cool, but I don't want that to just happen randomly. I'd like to actually talk about it and make clear decisions. When we did K-12 funding, there are radical differences between how the Arundel School District staffs its system for the time I was looking at this, the 8 children in that district, and how the Bellevue School District staffs their schools. They should be different, but we should think about that and not just like spray money around. So,
very good.
Intentionality.
Yeah. So I'd like one clarification on what you talked about the screening. You said it's the GAIN SS. So is that GAIN?
GAIN-SS.
Okay, I just wanted to clarify that. So
do a search on that. You'll find out what it is. Standard assessment.
perfect. So and then also during Patrick's presentation, there were questions around suicide training for foster parents, and I know you've addressed some of the training that we can overtrain people or give them more training they need. Is that something that could be made as an option for different foster parents?
Well, I mean, we have it available through the Alliance.
Okay.
And it's often the trainings that are available to staff are also available to foster parents through the Alliance. I don't know about this one. I'd have to get back to you. Paul, unless Paul's on or someone else is on and actually knows the answer to that question.
I'm sorry, I don't know the answer to that question. I seems like we do have a training, that foster parents can get to, but I don't know specifically.
We'll get you a written answer to that.
Okay, thank you.
And you're tracking what I'm going to get written answers for?
Yes.
Thank you.
Dr. Levy?
Thanks. I had a follow-up to this sort of concept of mental health and behavioral health. And in the medical world, we've had a lot of trouble accessing mental health and behavioral health services for our patients. So when you say you look to the healthcare system to help these children and youth, I get a little bit concerned just because we try that, and a lot of times we have a hard time accessing services because of capacity issues across the state. But what we have been able to do effectively in primary care practices is to implement behavioral health consultants as a model where they're embedded in the primary care practices. And then they don't do long-term therapy, but they're available to do kind of triage assessment and getting an idea of what the mental health needs are for an individual. And I wondered if you guys have thought about ever implementing that type of a process in DCYF with your caseworkers, who are clearly not always a mental health specialist, but have a lot of knowledge and might, benefit from linking with specialists more directly.
So, you and I share a concern about the availability of mental health, behavioral health treatment, the availability or lack thereof of substance use treatment, or at least of effective substance use treatment for parents, for youth in the system. We are not unique in not having access to that. At the very high end, we are all struggling in not having access to residential settings for children and youth who have very severe behavioral health needs. And again, every state is struggling with this right now. And I'm really not allowed to use the language that's appropriate to describing this problem in a public setting. So I'm not going to, but yeah, we're equally concerned. I'm probably more concerned than you are. And now the question then is it better for me to try and train my staff to become mental health professionals, or is it better for me to make sure that the one healthcare network that we contract with to provide services to our children is actually, putting enough effort into making sure that those resources are available, or is there some combination? I would rather have the services come from the healthcare system for two reasons. One is I think they'll be better received, is sort of the primary reason. And the second reason is they come from the healthcare system. They get paid for with Medicaid, which has a 50%, over 50% federal match for us. Whereas if it's paid for with 4E, we get about a 30% match. So I get more for my money if I buy it through Medicaid than if I buy it. Well, and I got to think about stuff like that, but mainly because I think it'll work better. And we find this when we look at things like home visiting, where if we approach someone and says, boy, the child welfare system is really worried about you, and we'd like to have a CPS worker in your house every week for the next 2 years, people look at you with horror, quite appropriately. But if the hospital at your birth comes to you and says, wow, you're qualified for something that your healthcare plan pays for a nurse to come visit you every week for the next 2 years and help you through all this new mom stuff, would you be interested in that? The take-up rate is a lot higher. Surprise, surprise. And so, I mean, what I just described is nurse-family partnership, which is probably the best functional system in the nation right now, or at least one that's been tried over and over again and has results. So a reason why it would be better to deliver it through the healthcare system. It's important for us to deliver it. It's important for us on the casework side to make sure that the kid's getting what they need. I don't really have a good way to track the delivery of this on a case-by-case basis today, which is concerning, and it's part of the sort of mountain of COBOL problem that we all struggle with at the state level. So I'd love to have more insight into what's actually going on day to day, but we got to figure out a way to get these services to kids one way or the other.
Okay, thank you, Ross. So I have one more question here. Question at the request of Representative Sent. How often do the courts take actions in child welfare cases that are counter to what the social worker / DCYF recommended? And is this tracked by the agency at an aggregate level, and can that be shared with the oversight board?
Anecdotally, we pull our hair out over this because, of course, we think that we're 100% right, but this is why people elect judges, right? Is that they have access to lots of information, and that's how that system works. We do not have a way to get access to this data. It's not tracked. It's unavailable. We don't even write it. We don't write it down. You'd have to infer from what we recommended. We send a document to the court does something different. You'd have to go through every single case and draw a conclusion. Did they do what we recommended? We don't have a score sheet for judges. Tempting sometimes, but we don't have a score sheet for judges. Close your ears, Justice Bridge. But we don't. And if we have a consistent challenge with a particular judge, we will hear from the Assistant Attorney General that runs that office, and it will rise up through the Attorney General's office, and we will have a conversation about that. But we very, very infrequently would do an intervention on that, unless we think there's an egregious problem, and the AG himself would have to approve any request that we would make to recuse a judge from particular category of cases. So that's not really a path for us to follow. We have a large engagement with the court system to try and share our engagement with the administrative office of the courts to train on how child welfare cases work, to try and get consistency across the state. And there are 39 different courts. They're all different. Many judges and commissioners, and they turn over every 2 years. Drives us crazy. But I can't give you a score sheet by judge.
Understand. Representative Kagi.
Thank you, Representative Dent, and thank you, Secretary Hunter, for coming to the board multiple times and really helping us understand how the agency is working. In the actual report on page 10 is a summary of the fatalities by category for open cases at time of death. 34% were open cases, and 31% were closed cases in the last 12 months. And I'm just wondering what the department, how much you are providing services after a case closes. I'm aware that the federal law, FFPS, allows the state to continue to support families longer than we have in the past. And I'm also thinking about the National Fatality Commission that Ben referred to, that they identified that childcare was the most effective intervention in terms of preventing fatalities. So it's really a question about how long do you provide services? Are you taking advantage of that federal authority? And how much impact do you think that would, would that help reduce fatalities for the cases that are closed?
So the children in foster care are categorically eligible for working connections childcare and have 12-month eligibility after their status ends. They're eligible for 12 months. So a whole year of childcare eligibility for those children. In many cases, if they are reunified, given the overlap of poverty and child welfare cases, it is overwhelmingly likely that the family is eligible for working connections. And we would work pretty hard to ensure that that family had access to service. Now, right now, it's hard to get childcare. We lost I don't know, 5 to 10% of providers during the let me see if I can pull this chart up from memory. We lost providers equal to about 5 to 10% of the capacity of the childcare system, the licensed capacity. Some of that is normal turnover, particularly in family childcare. There's a lot of turnover. People enter and exit the field regularly, so it's hard to say whether that was due to the pandemic or not. For the first year of the pandemic, we required providers to host their open slots, their actual use of slots. I'm not quite sure what authority we had to do that, but we were able to do that. That ended. One of the orders that were the emergency orders gave us the ability to do that. We no longer have that authority, and we don't know. Many providers don't have teaching staff adequate to meet their full license capacity. So there's a capacity challenge in childcare. Anyone who's looking for childcare will tell you this. They, like everybody else in the world, is short-staffed, and particularly in jobs that are underpaid. Our short-staffed and our childcare workers are underpaid. So I agree with you, Representative Kagi. That would be the best thing for us to do, is to provide more care. We have the ability to do that. I don't need to do FFPSA claiming to do that. I can just use CCDF for it, or I can use state funds for it. We'll try and figure out how to claim FFPSA in those scenarios. May not be worth the accounting aggravation.
Well, is that true of other services as well, whether it's mental health counseling or substance abuse treatment, or, providing that support for families after a child is returned home?
This is a good question, and I do not know the answer accurately. I'm not going to answer it. Childcare, I knew. I don't know the other ones. I'll go find out.
Okay.
Thank you. Good
Okay.
question. Hopefully I'll know by tonight.
And I have a second question.
Of course.
It is daunting, the number of recommendations that come your way as a result of these fatality reviews. And as you know, I participated in a number of them before going to the legislature. And just the amount of policy that is already in existence, and the number of bills the legislature passes, and
let's point out.
Just the amount of policy input that the department gets. How are you approaching that to really, obviously the caseworkers can't possibly implement all of the policy changes coming out of 124 recommendations. How are you addressing that? Just the need to really integrate and streamline.
I thought I addressed that up front is, when I took over the agency, there was no organized way to make decisions about what were we doing and when were we doing it in terms of implementing recommendations from these reports. I instituted a process where I have a committee of people who really do understand the practice in a deep way, that has our QA folks on it, has our analysis people on it, that are looking at all of the recommendations come in, and then they make a formal recommendation. Are we going to adopt? Are we going to not adopt some of these recommendations? And you saw in the report from Patrick, we adopted some fraction of them. We chose not to adopt a different fraction of them. Some of them are pending, and that we said we're going to do it. We haven't done it yet. We've done some of them partially because some of them require rivers of money that the legislature has chosen not to provide to us to do those We're gonna have live recommendation. Here's the summary of what they are. Trying to provide feedback to we get a lot of training recommendations, and in many of the cases, the people have been trained on this stuff already. Now, I'll use the diabetes example that came up earlier. The vast majority of children in care are under 5. So the problems that we have with diabetes tend to be parents or caregivers who are not, or teens who are not good at managing the really careful attention to detail it requires to effectively manage diabetes, and parents who don't have the capability or the intention of guiding their teenager to make sure that their blood glucose is being checked, that that they're managing their numbers. And in many cases, we do have training available for this. And I don't really think that's the solution to that problem. This is a really challenging problem. We put a lot of attention because it's a huge risk for a diabetic teen to try and make sure that we're on top of keeping that kid safe. It's not clear to me that additional training of that parent or caregiver is magically going to solve that problem. In fact, it's pretty clear to me that it's not. So in many cases, the recommendations are not actually good. Like, we choose not to implement them because we don't think that they will significantly impact the system. We make an explicit choice on each of them. We document what we're doing and what we're not doing. Patrick can figure that out from us now. It's easier for him to figure out because we're actually deciding to do or not do.
Okay, my last question is much simpler. Obviously, caseworkers are the key to implementing any of these recommendations and having best practice. I'm just wondering what the status is, given our struggles with workload across the board in terms of your hiring caseworkers and turnover.
Super good question that I'm not prepared to answer. Sorry. I prepared many things to answer today. That was not one of them. It's challenging, right? I mean, like, this is the great resignation in some ways. It's the strongest labor market in a long time. The private healthcare industry is hiring rapidly. We made a change in staffing. We put one of our regional administrators is now full-time leading a project focusing on retention. Retention is really the issue, not hiring. I'd rather not have a hiring problem by retaining our staff. We did a consult with New Jersey, which has an enormous, like, they have a turnover rate of like 2%. Trying to figure out what it is that drives retention, and we're trying to do that. A lot of it is peer support, how our management environment works. We are working diligently on that, and I will get a report out actually at, I believe, our next leadership team meeting from the team that is working on this retention project. We can get you obviously our stats on turnover. I just don't have a current set in my head.
And also, we have our meeting in 2 weeks from now, and workforce strategies, including recruitment and retention, is one of those topics.
There you go. So presumably I will have that answer at that point. Someone will have presented me with the data sets to provide to you. No one lets me do my own statistics anymore. It's terrible. It's actually a really good thing.
Yeah.
Right. It's an outgrowth of the fact, Representative Kagan, you will remember that the budget staff only gave me PDF files when I asked for things. They would never give me a spreadsheet because they were afraid I was going to mess with it myself and then pawn the work off as theirs. Probably a legitimate concern, and I had unbelievably great staff there, and I do here as well, who can get me answers to questions really quickly and mostly slap my hands when I try and do it myself.
It's because we can't trust budget shares. Lois Martin?
Hi, good afternoon, everyone. So Ross, you had mentioned something about the changes in the ability to attract and retain staff to do this work. And even in bringing in new staff, I know that you guys have had some changes in the agency itself, specifically around the racial equity and social justice group. So I'm curious as to what the plan is as you onboard new folks to be, made aware of the warning signs and to ensure that work is going to continue so that staff know how to work with a diverse group of families.
Excellent question, Lois. Thank you. We have, in the last several weeks, experienced one of the downsides of having really excellent staff, which is that people poach your staff and pay them 50% more. And so we have lost 2 of the 3 people that were running our racial equity and social justice group, which I am upset about. But I have to congratulate both of them on getting really high jobs that pay more than we're paying our chief of staff. So I can't compete on salary. And so we've grown staff who have gained capacity and have moved up in the world. And we have that same commitment. We're not going to lower our staffing level on that, and we'll figure out how we're going to hire. And I don't know how we'll replace Yvette and Day. I'm sure there will be a growth opportunity for people. Are you looking for a job? I have openings. No, like seriously, we will take that recruitment very seriously.
Okay, thank you for that, Ross. And Ross, you guys can't afford me, but thank you for the offer.
It's probably true.
Representative Kagi? Oh, you just hadn't taken your hand down. Okay.
Yeah.
It's usually a safe bet that she has a question.
Well, she always has a question. But do we have any further questions from the board? I mean, we still have a few minutes left. I mean, let's don't let Ross off too easily here. Okay.
I have some, if you're interested, we have a couple of, I had a couple of slides that I was prepared, and I could talk some about the intakes if people were interested in that. Can we bring those slides back up?
Sure.
So let's go back up to the top of it, to the first slide. So this was, so you asked a specific question earlier, and I should have brought this slide up in answer to that, which is looking at the top line is, again, the balancing indicator for the number of children in care. The lower one is a look at a breakdown of the children who experience an intake or a CPS intake or placement after case closure by age at the time they were returned home. And so you will see the distribution by age of the cases that are described in the top chart in the green bars in the bottom. Since most of the children in our care are under 5, it's not surprising that that's the biggest. Though interestingly, I'm not interpreting this correctly. So 0 to 3 months. What we're saying here is that almost 19. Vicki, you're on here, Dr. Ibarra. Make sure I say this correctly. If I'm interpreting this chart correctly. Almost 19% of children aged 0 to 3 months who actually, Dr. Ibarra, why don't you use words to describe the chart in green? The top chart I understand. let's make sure I say this one correctly.
Thanks, Ross. The bottom chart is intended to show the variation underneath the top chart by age group. We measure variation by different characteristics of children and families and location. In this case, it's by age of the child at case closure. So once a case is closed, within 12 months, was there either a new CPS intake or a placement on that child once they were returned home? And the 0 to 3 months is the highest group. So that group experiences, I'm sorry, I can't quite see that number, but Ross said almost 19% of those experience either a CPS intake or a placement within 12 months after case closure, which is quite high. Infants are considered among the highest risk of those children that we get intakes on. Infant and very young children intakes are more likely to be screened in because of both statutory requirements and the risk associated with those children. So I think those are combined, the reason we see that. I'll just use this as an opportunity to say Washington State has one of the highest rates of placement the highest percentage of our children placed who were infants in the nation were 3rd or 4th. We have a lot of infants going into care, and that's one of the reasons we continue to be concerned about this population.
So that was the answer to an earlier question. That makes sense to folks. That helpful? The next slide is the detail that I referenced of the suicide item and the percent indicated on the GAIN SS. And the difference that you see by caregiver type where, and remember, this is done within 30 days of placement. So to see that much variation in the suicide item between relatives and non-relative foster care is in that short a time period it works better to have kids with relatives. There's lots of data about that, lots of other studies on that particular topic. This was us trying to look at the results from the GAIN SS and make sure I had some numbers to talk to you about suicide. The next charts are the next couple of charts. Let's go to the next one. You saw this one. I talked about this one, so let's go to the one after that. This one is looking at some of the leading indicators for how do we look at the business of what's actually happening? Can we predict, are we going to have to hire a whole bunch more caseworkers or a whole bunch more investigators 4 months from now? Just sort of trying to predict, what are we going to need to do here? But what you see, what I thought was interesting is the CPS intakes and the gray line where the pandemic was and the changes as a result. So the height of the bar on the colored bars on the left is the total number of intakes per month. And you saw a sudden drop at the pandemic because kids weren't going anywhere, right? They were just at home. Parents rarely call CPS on themselves. And it's ramping up slowly as kids returned into more and more settings where neighbors, teachers, medical professionals saw them. And we're now looking at our forecast for this year on intakes is pretty much back up to where we were pre-pandemic. It's very seasonal. We see intakes happen at lots of times. Mostly it's after they've been on vacation for a while and they return to school. But the other thing that I think is interesting is that there's much less volatility in the blue part, which is the screened in, which are the more severe concerns. And then you see the entries into out-of-home care and that long-term trend down. Again, with seasonality, it bounces around a lot. Our entrances into care continue to be below our exits. So that just sort of, if you have a line at the bank, no one goes to the bank anymore, but if you have the line at the bank and the tellers serve people faster than they come in the front door, that stand in the line gets shorter. And that's what you're seeing in this particular slide, that's just the math of it, of what you're seeing in this slide. Let's go to the next chart here. And so these are indicators that we look at across the business to make sure that we are, that our whole leadership team understands the different parts of the business. This is the child welfare part of the business, because that's what you guys were asking about. We have indicators at this top level, our priority indicators in all the different areas of the business. I can't read this one from here, and this was a new chart that I had not seen. Oh, this was the pilot we did. We screen out 800 a year pre-pandemic calls to the hotline for people who are pregnant and are using, but there's no child, so legally it screens out. There's no child being abused. But we know that we would wind up removing half of those kids 4.5 months later on average. And so we wanted to do an intervention, like, well, can we make this better? And the answer is yes, we can make it better. So we're doing a pilot to get families connected to services. Just the care coordination alone improves outcomes in this space. And even if you don't get them access to the substance use treatment, but getting them access to treatment, it works better. So it is a pilot that is working. We're excited about that. We'll be happy to come back and look at that later. This is one of the strategies that you want to use to reduce the need for intake, is if we can get that mom involved in treatment, ideally like in residential treatment, so that you don't have to have an intake. Like all of a sudden we've reduced intakes and we've reduced removals, not by changing our policy downstream, but by preventing the potential abuse upstream. And this would be highly leveraged, way cheaper, way better. And this is a population where we know 50% of those kids are going to get removed. For God's sakes, let's invest in the substance use treatment up front. Let's go to the next one. And so length of stay, this is one we are looking at. One of the strategies we have on length of stay is going up. Now, there's a bunch of reasons for it. Some of it is the challenges we have in some of the court systems. Some of it is as we reduce the, it's a statistical problem, which is as you reduce the number of kids coming into care who really didn't need to be in care, they're short stayers. So we're removing a bunch of short stayers from the average. And so now the average is made up of longer stayers, even if the absolute number of longer stayers hasn't gone up, and it's actually gone down. But the relative percentage, which tends to drive up length of stay, one of the ways that we think in the long run will reduce length of stay is by increasing the kin placements. In the absence of having a guardianship option, which you guys have fixed, thank you, it tends to have longer length of stay with kin. But we think that a lot of that is just masking cases that are effectively guardianships. And our ability to license kin allows those kin to get resources equivalent to non-kin placements. So when we started, we were at 46%. We're now at 53%. It's exciting. That's a lot of movement. We have some areas, King County is touching 60%. Like some months it's over. It's exciting. That's like, I would like to drive the goal to somewhere in the 65–70% range. I have absolutely no research base that supports that goal. And so I'm not like putting a stake in the ground at that. But as we continue, we know we can do better than this. I don't know what our eventual, where we'll wind up. We will not wind up at 100%. We would like every single relative placement to get the same financial support that a non-relative placement would get for the same child. It is unconscionable to me that we ask some grandmother to take care of her grandchildren on a fixed income and we don't give her any financial support to do so. She's going to take her grandchildren because that's what you do. as family, but is going to struggle. And we think if we provided the resources, the way that we can do it without legal changes is we just do the work to get them licensed. Our child-specific license will make a big difference. We're getting those already. We've already increased by focusing on this and changing the perception of our licensors in the field. We've almost doubled the percent of kin who are licensed. I will hear about this from the budget forecasting staff at some point, because it's like, that's going to cost money. It will save money in the long run because I will have children who have much less behavioral health challenge. These two paired together is increasing the placement with kin and getting those kin to be licensed. You should see big jumps in this licensing number in the next year or so. I'm excited about it. Another of our sort of leading indicators, places where we think there's leverage, is placement moves. Every time we move a kid, it delays permanency for that case. And you get more than two or three moves in a case, the likelihood of reunification goes down. Now, this is not entirely causal. These are really complicated observations. So we're looking at placement moves per 1,000 days in care. This is the world's most complicated statistic to understand. I tried to unpack this in my head the other day. And so that's not saying that a kid gets 4, whatever that first column is. It's this is disaggregated by race is American Indian, Alaska Native. It's not saying that they get 4 placement changes per kid. It's kids adding up to 1,000 days in care. That many placement changes will occur. If there are a lot of short stays, the number will go higher. The gray bar is a state measure where we look at just the first 90 days, which includes a lot more short stayers than the federal measure, which is the blue bar. This is like an arbitrary statistical number. It's better if it's lower, but it's not, each kid did not get on average 5 moves. And so we probably should have a way to translate this into something that makes more sense to people, but this isn't that. And this is probably beyond my ability to screw with the numbers and come up with the right answer. I asked this question the other day. So it's a thing that we are just starting now to focus on, is how do we reduce the number of placement moves. So we stabilize caregivers. One of the strategies around that is you increase the number of relative placements, they're more stable, and you provide resources to relative placements so that the kid doesn't blow out of the placement because there isn't enough money to handle cases. We're also doing work, and you'll see a decision package from us this year on consistent resourcing of the entire placement continuum. So foster care rates, but also for the first time, really sort of trying to guarantee respite and other resources to all of our caregivers so that they're really getting the resources they need to care for children, and improve placement stability, because it's better, it's enormously better for children, and it makes the system work better. So these are things I wanted to talk about because I have the numbers, and these are indicators that we are looking at our leadership level to try and understand what are we doing. So there you go. And but I think we're out of time, and I have a 2 o'clock meeting that I'm supposed to be at back in the office. That is with AGs. I gotta go.
I understand. Well, thank you for coming today and sharing this information. We appreciate it. You gave us a lot of information. I appreciate it.
Try to be helpful. Thank you.
And Patrick, to you too as well. You gave us a lot of information, and appreciate your time, energy into this effort and helping us to understand what's going on, and help the entire board get their head around this, which is, these are difficult, hard issues, and it takes something to do so. And I'll be seeing you in a week or so.
Sure.
Okay, right on. Thank you. So we're down. Back to my agenda here. So the board. Any questions, comments about everything that we've heard here today? And anything you would like to share on your thoughts?
Thank you.
But don't all raise your hand at once, you know.
Oh, thank you.
Well, I for one feel it was an extraordinary amount of information, and I was really looking forward to hearing and to understand some of this a little bit better. And I really feel a little overwhelmed now at everything that we've heard. But I have heard some good things that I really appreciated. So, Lois has her hand up. Lois?
Well, I just wanted to share with the group, I've had I have participated on some of the fatality review committee, and it is probably one of the most sobering experiences I've ever had in working with young children. But also understanding the importance of the work as we find different ways to protect our children and support our families. You know, I can even see some of the advancements that the department has made, as well as implementing the suggestions, but we still have a long way to go, especially in supporting families and foster parents, particularly as, you know, we navigate that line between trying to reunite our families with their children and what is best for the child. So I just want to encourage or to continue to be open to hearing the stories from families and especially foster parents, and doing what we can to support the childcare field, because I think I'm concerned about staffing shortages we have across the board and how this impact quality as our teachers are coming off it now, and look at the way we can support them and with new
Lois, we're not catching everything.
programs.
Lois, we're not catching everything you're saying. You're going in and out.
Are you still there, Lois?
I am here. I'm not sure. Can you guys hear me now?
Oh, we can now. You're very
Much
clear.
better. Thank you.
Okay, good. Sorry about that. I'm not sure where I left off at, but the bottom line is I was just saying how important it is for us to continue to encourage the department to support our foster parents and as well as our families as they walk that line, that very thin line between trying to reunite our children with their families versus what's best for the child. And I had shared, I think you guys heard this piece, that I have sat on one of these committees before, and it's very boring work. And the department has made advancements. I still feel that we have quite a ways to go. And my concern is around, even in our childcare settings, as folks struggle to find staffing, how much more of this can happen as the caregivers become fatigued and maybe miss some signs, or, you know, especially with our social workers. So just finding ways that we can, as we think about our annual report, encourage the governor's office and the legislature to begin to find some innovative programs that we can use to attract and retain staff, because I think that is one of the biggest defense mechanisms we have to be able to keep children safe. Thank you.
Thank you, Lois. Dr. Levy?
Well, I guess I'm kind of interested in where we can translate these types of presentations into action. And I don't know, maybe we can't. I mean, I think it's very helpful to look at the data, and I really appreciate both presentations today because it was filled with so much information, kind of mind numbing and to some extent. But I think if we look at the data, that really helps us see trends. And, my comment about where do we know what's working and where do we know what's not? And I also wonder for the legislators on the panel, is this the type of thing that helps you translate into your work as a legislator, where you can sometimes take things that might be a need or something that might be missing? I don't know, just some thoughts about that.
Well, thank you for those thoughts. For me, what I think about when I see this, and as the oversight board, and the way we had originally envisioned it was to watch, from the 30,000-foot level, what the department is doing, the agency's doing, and I see that they have made some changes, and some of the changes are beginning to show themselves now. We're seeing the fruits of our labors, and I do see some improvements in where we've been with the agency and with our child system, our child welfare program. So that's what some of the stuff I gleaned from today was improvements. But there are some places we hear a lot of information about how we could improve it more, and that's something that we can work on as we go. But I thoroughly, you're right. This was mind numbing today. I'm feeling tired, because we've heard so much and trying to focus on it. But Representative Kagi.
We can't hear you. You're muted.
Thank you, Shonda. Well, I have a lot of historical perspective on this, because sitting on fatality reviews is one of the reasons I ran for the legislature 25 years ago. I sat on 4 different fatality reviews and was horrified at the status of child welfare. And at that time, fatality reviews were not required for every death. It was only the most, the ones that hit the newspaper. So I think it's really encouraging that deaths are being systemically looked at, and it's done on a regular basis. And the department has a process for really looking at those recommendations, and the fact that outside people continue to be involved in those reviews. I'm just very encouraged. And like you, Representative Dent, I also am encouraged by the direction the department is going. But clearly, as Lois said, the issue of workforce, I'm really glad that we're going to be addressing that in a couple of weeks. But that is so crucial to the department really improving practice and being able to keep children safe and help families thrive.
Senator Wilson.
Thanks, Representative Dent. I was just going to respond to Diane's wonder, and as Chair of Human Services, Rehab and Reentry, it's one place where you gather information, but I also have stakeholder groups keeping families together. I sit on Extended Foster Care Coalition. I also sit on the Foster Care Commission. So it's really gathering that information and looking for themes, if you will. I also look to see whether the requests coming perhaps from DCYF and the agency are aligned with what we're hearing out in the world of those folks that work in that cross-system sector space. So for me, it's very much information. I also think it just bodes to the fact we spend a whole bunch of time on intervention, and we're the only place in the world that feels like you got to do the wrong thing to get what you need to do it right, which is also why sitting on early learning in K-12 is also a good space to be, as I am informed by the information, because if we look at prevention services, these are no longer poverty programs. These are programs that all families need and all children need as we think about our current world today. So for me, it's one place of information, not the only place, but also having been outside of the system for a long time, I also am seeing movement from within. The institutional movement always takes longer than one would like. And the other piece is total agreement with Representative Kagi about the workforce issue, and the fact is it's every profession right now, not just this profession. So as we look at any helping profession, we are struggling with how it is we are bringing people in, as well as sustaining those that have maintained their time with us, because it is critically important. And I think our helping professions have been impacted greater than some others, because they also are oftentimes the lowest paying job. So clearly critical and an urgent issue we have to consider.
Thank you, Senator. Any other comments before we close today? You know, another thing that I thought about too is that we talked about the recommendations. Many of the recommendations been made by OFCO, and the discussion we had around that was that the DCYF has been paying attention to those recommendations and doing what they can to implement the ones they can, and reflect on the ones that they're not able to do. So to me, that's a positive as well. I mean, you know, I see some change from where we started, Representative Kagi back in 2017, I think, and to create a new agency and change the culture. There's times when I wonder if we've been doing that, but I feel a little better today because I think we have changed a few things, and I'm feeling good about that. I know we're not where we all want to be, but we're making headway, and that's what it's about. So, any other comments before we adjourn? Hearing none. Thank you all for coming. I truly appreciate everyone that comes to this meeting, those who are on the board and those who come to listen in and pay attention to what we're trying to accomplish here. And your participation is invaluable to some of our less fortunate young people in the state of Washington. So thank you for that. Thank you for the support. And with that, we'll adjourn. Thank you.